Good morning. Welcome to Boston University and to the MassCPR Symposium, Pandemic Preparedness, a Global Framework. I'm Ken Freeman, Interim President of Boston University. I'm pinch hitting today for Bob Brown, our President Emeritus, who is unable to join us. It's wonderful to have such a large audience in person and many more joining us virtually. COVID-19, as you well know, changed the world's focus on deadly infectious diseases. At BU, we toiled for over a decade to establish the National Emerging Infectious Diseases Laboratory, also referred to as the NEIDL. We were concerned that the day would come when the world would need to respond to a pandemic at an unprecedented level. And it happened, as you well know, in the spring of 2020. The theme for the symposium is the exploration of ways leading health organizations and universities can come together to be prepared for future outbreaks of infectious diseases. The Massachusetts Consortium on Pandemic Preparedness, or MassCPR, was founded in March 2020 to confront the immediate and long-term challenges of COVID-19 by mobilizing more than 800 basic and translational scientists, clinicians, and public health professionals from 17 institutions throughout Massachusetts. During the past 3.5 years, MassCPR has demonstrated that cooperative work across institutions, scientific disciplines, and borders, it works, and that it's essential to overcome major health crises. However, there's much more work to be done. As the world's leading health organizations make plans to tackle new infectious outbreaks, their efforts highlight scientific and organizational gaps that remain to be addressed. This year's MassCPR Symposium is specifically focusing on identifying, discussing, and closing those gaps. Other than working together to moderate climate change, I can't think of any more important collaboration than to collectively prepare the world to fight the next potential global pandemic. To be successful, we will need to interconnect all of our resources across institutional and national boundaries, and today's symposium is a wonderful starting point for moving forward with this very important task. We have a tremendous group of speakers representing leading organizations who will offer their perspective on their preparedness, including the University of Global Health and Equity in Rwanda, the INRB in the Republic of Congo, the World Health Organization, the Coalition for Epidemic Preparedness Innovations, or CEPI, FIND, a global nonprofit connecting countries and communities, funders, decision makers, and healthcare providers and developers. We also have speakers from the United States government representing NIAID, the FDA, the Department of Public Health, and the White House. We'll begin today's deliberations with an amazing on-the-ground view of the pandemics, as we are honored to host the Right Honorable former Prime Minister of New Zealand, Dame Jacinda Ardern, and her two former scientific advisors who will engage us in conversation about their experiences leading a nation during the pandemic. Please join me at this moment in thanking the symposium co-chairs for their efforts that made today's symposium possible. Dr. Richard Hatchett, CEO of CEPI, and Dr. Nancy Sullivan, Director of the NEIDL, the National Emerging Infectious Diseases Laboratory here at Boston University. Now it is my honor to introduce Dr. Louise Ivers, who will facilitate our first session. Dr. Ivers is a director of the Harvard Global Health Institute, director of the Massachusetts General Hospital Center for Global Health, and the David Bangsberg Endowed Chair in Global Health Equity at Mass General Hospital, where she's a practicing infectious diseases physician in the Division of Infectious Diseases. Dr. Ivers works on the implementation of health programs with the goal of advancing health equity and access to care and social services for impoverished communities, supported by research and advocacy. Dr. Ivers, please join us today.
Good morning, everyone. Well, in 2020, as the COVID pandemic emerged, science and the evolution of the science was the same everywhere. But the policies that were enacted, the leadership each of us experienced, the public trust, and the social context into which the virus landed were very different. These different factors resulted in very different outcomes across the globe, and they merit our careful consideration in thinking about the future. In Aotearoa, New Zealand, then Prime Minister Jacinda Ardern led a government response that was swift and impactful. The initial COVID response in New Zealand is considered to be, by many people, exemplary. There's no response that has been perfect, and no single statistic can try to summarize the pandemic experience, but I'd like to offer this stark one. Confirmed COVID-related deaths per population in New Zealand were 1/5 those of the United States. We're very lucky today to have this panel discussion, a wonderful leadership team to share more with us about their perspectives for pandemic preparedness and the future. I'd like to introduce the Right Honourable Dame Jacinda Ardern. Born in Hamilton, New Zealand, she completed a Bachelor of Communication Studies in Public Relations and Political Science, and after university worked as an advisor in the office of then Prime Minister Helen Clark. She joined the New Zealand Labour Party at 18 and entered New Zealand's Parliament in 2008. She served as the 40th Prime Minister of New Zealand from 2017 to 2023. During her time in office, then Prime Minister Ardern inspired a global generation with her compassionate, empathic leadership. Dame Jacinda was awarded an honorary Doctor of Laws degree by Harvard in 2022 and was appointed Dame Grand Companion of the New Zealand Order of Merit in 2023. She is currently Angelopoulos Global Public Leaders Fellow and Hauser Leader at the Harvard Kennedy School and the Knight Tech Governance Leadership Fellow at the Berkman Klein Center at Harvard. Please welcome Dame Jacinda. And our online guest with us, Professor Sir Ashley Bloomfield, is a physician and distinguished public health expert. He served as the Chief Executive of the New Zealand Ministry of Health and the country's Director General of Health from 2018 to 2022. In the role of Director General, he was the public-facing health specialist during COVID-19 pandemic in New Zealand on behalf of the government. Sir Ashley worked in a range of executive health leadership roles in New Zealand prior to that role, and he was appointed a Knight Companion of the New Zealand Order of Merit in 2023 for services to public health. He is currently a professor at the University of Auckland and the co-chair of the WHO International Health Regulations Working Group. Welcome, Sir Ashley. Professor Dame Juliet Gerrard is the New Zealand Prime Minister's Chief Science Advisor, a role she has had since 2018. She's a professor at the University of Auckland. Dame Juliet is a distinguished biochemist whose work spans many areas and whose academic research is in protein biochemistry, investigating protein-protein intersections, and applied research in the food industry. For services to public health, she was appointed a Dame Companion of the New Zealand Order of Merit in 2021. Welcome, Dame Juliet. So I'd like to thank you all for being here, and especially to our colleagues in New Zealand, where it's really the middle of the night. Thank you very much. I wanted to begin by asking each of you to share with us your high-level perspectives on what we should be thinking about for the future based on your experiences, and I'll start with you.
Thank you, Louise. And can I start by thanking all of you for the invitation to be here, but particularly I'd like to thank my two colleagues in New Zealand. It's 3 a.m. where they are, and my thanks is not only for their attendance and their generosity to share their wisdom, but I take every opportunity I can to acknowledge that our response in COVID was a team effort, and you have before you the two individuals I relied on the most during COVID-19. New Zealand's pandemic response would not have been what it was were it not for these two individuals in particular amongst a wider exceptional team. So I want to acknowledge them both. my really quick thoughts, after the privilege of serving in the role of Prime Minister, I'm now trying to spend a bit of time reflecting on 5 really challenging years. And I was sitting in a lecture on campus at Harvard University conducted by Dutch Leonard, where he talked about crisis leadership, and he said something that really resonated with me, that there are 2 distinct forms of crisis leadership. There's routine crisis for which the public will expect you to have some kind of off-the-shelf plan that in the event of an issue, say fire or earthquake, something that you can predict, needs to be pulled out and then deployed. And in those cases, the public expectation will be relatively high because it's something that you should have predicted and planned for. And then there's those crises which you could term genuine crises, for which it is very difficult to plan and prepare. Now, we were given a certain amount of grace during the COVID pandemic because there was a general sense, I think, in the wider population that this was somehow unexpected. But for those who work in this space, it was not something that should have been unexpected. And so whilst we had that level of grace in round 1, we will not have that level of grace in the inevitable round 2. And so what are the factors that I would implore those who have the privilege of political leadership, and I'll leave it for my colleagues to speak about the other aspects, but for political leadership. I often get asked, how did you make such decisive decisions during COVID? Well, I can tell you, decisive decisions don't come from being a personally or individually confident person. In fact, they are quite separate things. I speak very openly as being someone who suffers from imposter syndrome, but when it came to decision-making on COVID, I was very clear-minded because decisive decision-making is not personal. It's about the level and quality of the information that you have in front of you. That's what enables decisive decision-making. So the first prescription for me was gather all of the data that you need, as much as possible, in order to make a decision. Second, bring in all the advice and expertise that you can access. Humble yourself to the situation. Demonstrate true humility, because you will not know all of the answers, but there are people around you who will help you in the absence of them. And then the third critical factor is then, only then, apply your values frame over the top. Instinct should not kick in as your first response, but your third response, because sometimes you will have competing advice. So those are some very quick reflections for me, and that I think is how we were able to make decisive decisions, was because of that policy, that decision-making framework.
Yeah, thank you so much. Let me turn online. Dame Juliet, we'll turn to you next.
Thank you, and good to see you all. It's very hard to capture in just a couple of minutes all the experiences and impressions that we formed during COVID, but I'll just offer a few reflections. So one of the things that I did when I first took on this role was adopt some principles. They were actually published in a Nature paper by Donnelly, Valance, Whitty, and some others. I call them the Rita principles. So that was rigor, inclusivity, transparency, and accessibility. And whatever situation I found myself in terms of advice that Jacinda might need, that was a good check for me to run a lens over and make sure that what we were doing met those principles. And in COVID in particular, the last 2, transparency and accessibility, were really important. So we needed all the data we could, but the data was changing at the beginning incredibly rapidly. So that transparency, not only in the information coming through, but just how vague some of it was, what we knew, what we didn't know, was just as important. And when we might be able to narrow some of that uncertainty. So I can remember advice on a Wednesday that was completely inaccurate by the Saturday. And just not undermining the credibility of what the scientists were saying by adding on that uncertainty as we went was really important. I think the other one for me was accessibility. I actually went back and had a look at that paper a couple of days ago and noticed that the way it's framed in the paper was about accessibility of the words used, the advice given, and just making sure it's given in plain language. I broadened that out considerably to make myself accessible to scientists, to stakeholders, to anyone who had information, be that nationally or internationally, and in particular to the Chief Science Advisor to the Ministry of Health and to Ashley in town. So we were joined at the hip in our advice, and we were blessed with an incredibly enthusiastic national team of scientists who went off willingly and burrowed down every rabbit hole for us to make sure that we had the best information to filter up. International connectivity was really important for me too. So the middle of the night seems highly appropriate for a COVID discussion because I was often on the phone to my counterparts around the world. I guess the last point I'd make is that we didn't convene a formal group of science advisors and scientists. We remained very flexible. We relied on strong networks, which I think is probably easier to do in a small country. And I'm grateful that we didn't lock ourselves into some sort of formal science council, because the disciplines and expertise that we needed as the pandemic progressed were very different. So we started off needing virologists and respiratory physicians and ended up needing bioinformaticians and wastewater analysis. So I think that flexibility and adaptability served us well. Thank you.
Thank you. Sir Ashley.
Well, thank you very much, Louise. And Morena Koto, that is good morning, although it's good morning from the future in New Zealand, Aotearoa. Thank you very much for the opportunity to be part of this conversation. 3 quick points I want to highlight, and some of these build on what my 2 colleagues have already mentioned. The first is, of course, that preparation and planning are important. However, they are not so useful unless you do have really good, humble leadership and decision making. And with that, a huge focus on communication. And that communication needs to be trustworthy, and trustworthy in defined in 3 dimensions. That is, it is honest, it is reliable, and it is competent. And when I'm reflecting on our experience through the pandemic, I often talk about communication as being our most important public health intervention. And in terms of preparation, of course, we had the Global Health Security Index, which presciently was released in late 2019, which had the USA and the UK as first and second in terms of preparation for a forthcoming pandemic. New Zealand at that point was a lowly 35th. And I guess what the pandemic showed us, that yes, preparation is important and we should put effort into that, but it needs to be accompanied by, in the moment, very agile decision-making and leadership. And in particular, as Jacinda has pointed out, leadership with humility. That is, understanding the complexity, knowing you don't have all the answers, being prepared to seek advice, and most importantly, be prepared to change your mind when new information comes along, and to be accountable if the response doesn't go as well as it should have, fronting up, and that actually builds trust. The second quick point is just around how important in-country inequalities or inequities in health are when an event like this comes along. And even in New Zealand, where we were running an elimination strategy, when we did have community outbreaks, it was predictable exactly where the virus would show up and the groups that it would affect. Our Māori and Pacifica populations, people with mental health disorders, homeless people, people with addictions. And I'm often asked, what's the best thing we can do to prepare for the next pandemic? And I would argue that one of the most important things is that we address existing health inequalities. In New Zealand, we found that for people under 60, having a pre-existing condition conferred an additional risk that was 78 times higher of dying from COVID. So it was by far the strongest risk factor for premature death from COVID. And the third point, of course, is, and I'm sure we will talk about this a little more though, is the real importance of us collectively and globally preparing and ensuring we mount a globally equitable response. And the big challenge in this regard is what I call collective global amnesia with rapid onset. And the challenge of the process I'm involved in, the review of the international health regulations and indeed the parallel international negotiating body on an accord, the big challenge there is, of course, is that the attention of the world has moved on very swiftly. And we need to capture this moment now to improve our collective preparedness and our prevention, or that moment will be lost. Thanks very much.
Thank you. There's so many questions that I think we all have, but I'm going to try to dive in and touch a bit deeper on some of the things you mentioned. One of the things that to me is so apparent is that you're master communicators, and both individually and as a team. And I would love to hear your perspectives on communication strategy in this context, in the crisis context, and specifically the COVID crisis. Did you have a plan for that? Did you map it out? What advice do you have?
I don't know if this will give comfort or have the opposite effect, but the answer is no. And I think what's really critical when people reflect on the communication strategy, if we loosely call it that in New Zealand, you can't communicate with clarity unless you have a plan. And so it was the plan that we anchored ourselves around, and by being very clear-minded about what that plan was and actually working really closely together to develop it, that's what put us in the best possible position to then communicate it. But key, I think, and again, we didn't develop a communication strategy, we just made the decision that we would share information in real time. As we had it, we would share it. And I think one of the issues that we have, particularly in political leadership, is we believe that in order to give the public confidence in our leadership, we have to demonstrate absolute knowledge, absolutely. That is, at all times, we have to give a very direct response that demonstrates that we have all of the answers. But here was a clear example where it was obvious to the world that we didn't. So being able to say publicly, we do not know. We do not know where this is taking us. It was okay to say that as long as in the absence of information, we still had a plan to protect the population as much as we were able to, while of course information came to hand. So transparency was key, and as Dr. Bloomfield said, that enabled us to pivot because as we shared that information in real time, people could see if our R value was going up. They could see if our strategy was working or not, and they would understand then the need to pivot very quickly and came with us on that journey.
Thanks. And to probe a bit more on that, for political leaders, often changing your mind is seen as a flip-flop or a bad thing.
A flip-flop, or universally bad. If you change your mind, it's either weakness or poor initial decision-making. We do not have, I think, a political environment where at least the commentators are open to it. The public, I think, much more so.
Yeah, thank you. Juliet, you described in an interview that I read that you're the science advisor to the Prime Minister, not the science advisor to the public. And it struck me as a very important point that I wanted to ask you a little bit more about. I think we saw a lot of scientists, researchers giving their opinion very widely in the early days of the pandemic, and that can create confusion. Can you say a little more about your approach to that, as now still the chief science advisor to the current Prime Minister too?
Yes, thank you. It was important for me at the beginning to really clarify all those communication roles. So I did spend time talking to the press after decisions were made, clarifying the decisions, and sometimes behind the scenes, helping them locate information or locate other science communicators. But we had Jacinda and Ashley as very clear and gifted communicators who were giving those high-level messages, and that took a lot of time and energy. And what I did instead was coordinate, to an extent, some of the science communication with other individuals who had different expertise, different approaches, provided a more kind of inclusive collection of voices. And we really worked hard as a group on not just the science that needed to go to the PM, but also how that science might be communicated, and making sure that policymakers, politicians, and scientists were all using the same terminology when we were at some of those crunch points and we really needed the public to come alongside. So perhaps the best example is describing that people shouldn't leave their bubble when we were asking them to stay home. So that we didn't want lots of people using different terms and wondering who was in your family or who wasn't in your family, or whether your apartment counted as a house or not a house. And so this term bubble came up. I think it was Jacinda that came up with it originally, and the science communicators very quickly embraced that. We even had illustrations of bubbles just to try and get that consistent messaging across. So I think it was an important part of my role to make sure the science communication was being done, but not necessarily to do it myself.
Thank you. Ashley, one of the things you became very well known for amongst many were the 1 p.m. daily briefings. And I'm curious about your experience in doing that, how it evolved over time, how you felt as that was important in terms of communication. You've mentioned getting immediate feedback on that. Could you share a little bit more about that, how that informed your own communication approach?
Yes, thank you. And we started those daily stand-ups, myself and my Director of Public Health, a wonderful colleague, Dr. Caroline McElnay, I think the day before the WHO declared a fake, so very early on. And in part it was to manage the overwhelming number of media inquiries coming through, as we just decided to do a once-a-day stand-up and provide all the information we could there and come back the next day and do the same. And something about that, well, there are two things that strike me about that, and one of them, Jacinda has already highlighted, that it's actually okay to say we don't know, that it's just as important to be really clear about what you don't know as much as what you do know, and that that actually doesn't undermine trust, just as it's important to come back and say if you've changed your mind and why, if you have new evidence. The second thing is, I think the regularity of it was just so important in helping take the public on that journey of building trust. Both before we had our first lockdown in late March 2020, but also during that period in time when, as Juliet's described, we were asking people to stay at home in their bubble. We didn't know for how long. We didn't know what to expect, but every day they knew there was something that brought everybody together. That is, at 1 o'clock, they would all be updated with all the latest information. We didn't hold information or knowledge back as power. We shared everything with everybody at the same time. So no one was privileged with the information. And I think that was really important in terms of creating that sense of solidarity and of collective ownership of the need to look after each other, the be kind bit of the sort of invitation to action. So those were the things that sort of I really took from that regular communication. And even on the days when, and I did over 300 of them during the pandemic, even on the days when I really didn't feel like doing it, because it was quite an ordeal, really. It was that sense that this was so important for the public, and as Juliet said, it became a really time-consuming but vital role for myself and either Jacinda as the Prime Minister or one of the ministers who was leading the response.
There was one additional element that might be a bit of a quirk for New Zealand as well, because we were running an elimination strategy. It really did sometimes come down to individual cases. If we suddenly had a case of COVID emerge, then suddenly the entire country was interested in the contact tracing of that one case. And that was because if we could identify where it came from, then the public knew the shorthand for that was short lockdown. We'll only be in for 3 days if we can figure out what happened. So sometimes they would tune in to be like, have they figured out the connection between case A and case B? And the whole country became an epidemiologist. And so there was an odd little element of intrigue and mystery that became part of the community's engagement as well, for better or for worse.
Yeah, thanks for that. I mean, one thing that you spoke about early, and I think we observed from afar, was about unity and trust.
Yeah.
And you were quoted as saying, we united in an extraordinary way and we saved lives and livelihoods that way. But this wasn't the case in many countries. So there's one part there that the strategy of contact tracing, say, brought people in, but what other factors do you think in New Zealand or through the leadership created that sense of cohesion that we are in this together? Is it something hard to describe, or how could we tap into that in our own communities for the future?
I do think, and it is quite hard in a short space of time to describe New Zealand culturally, but I do think that there is a sense of collectivism or a desire to, if you're able to look after one another, then you'll do that. And maybe it comes from being a relatively isolated place. But in sharing the trade-offs and the choices that were being made, but also in making a decision once we already had insight into what was going on in the rest of the world, I think that made a big difference for New Zealand. So keep in mind, our first COVID case arrived in New Zealand on the 28th of February, so a bit later than most. And at that point, New Zealand was watching Italy. It had watched Wuhan. It had watched what was happening. It was taking it incredibly seriously, and there was fear. So when there was suddenly a strategy that said, actually, we're all in this together. Here is how you can contribute. You are empowered now as a part of this strategy. This isn't something that has to happen to you. We together can choose a strategy that will help protect one another. It really felt like there was almost a sense of relief when we said we are going to try and eliminate this. And that's how it felt to me anyway, but I think it did make a difference that people saw the alternative options when we made that decision.
Thank you. I'll turn a question about equity, and you've mentioned this. I know that influenza in 1918, you've mentioned, had a very big impact on the Maori community.
Yeah.
How did that history inform your approach? Because looking to the future, we saw in the US and in many places a huge disparity in who was most impacted. And equity really doesn't happen by chance, it only happens by choice. So how did that history inform you and the team's approach?
Well, so, Dr. Bloomfield's already referenced, for us it was both being aware of our history, but also being aware of our existing inequalities. And I remember our Ministry of Health presenting to us very clearly that, of course, amongst our Māori and Pacific communities, we already had significant health inequalities. We had prevalence of comorbidities that we knew would mean that COVID would hit those communities more. And so that was presented to us very clearly. If we make a decision where COVID takes hold in our communities, more Māori and more Pacific peoples will die than in the general population. It was very clear. And so we were very clear-eyed, I think, about factoring that into our sense of responsibility. And add to that, in 1918, my recollection is that the death rate for Māori was something like 8 times higher than the European population. And I think, as I also mentioned to you, we factored in our wider Pacific. We are the gateway to the Pacific. To get into the Pacific nations, you very often will come through New Zealand. And in the influenza pandemic of 1918, a passenger and cargo ship travelled from New Zealand to Samoa with influenza on board. 22% of the population were wiped out by influenza. And so I remember having conversations with our team about that as well.
Maybe to turn a bit to, and you can please bring in those themes too, but to turn to our colleagues online. Once vaccines became available, you had a rapid rollout of vaccine delivery. How do you think that the issues of trust, health systems, the existing issues played out in terms of vaccine uptake in New Zealand? And maybe I'll start with Ashley and then to Juliet on that topic.
Yes, thank you. And the trust issue again is a key one here, and perhaps just a quick comment on trust levels in New Zealand, trust in institutions. We did see, of course, after the global financial crisis, that trust in institutions, government, the private sector, even civil society did decline in many countries around the world. And New Zealand didn't experience the same level of decline in trust. And in fact, during the pandemic, in the annual surveys of trust, that the Edelman Group does, the Edelman Trust Barometer, we saw New Zealand as the only high-income democracy where trust went up quite significantly during that first year of the pandemic, whereas it declined in most other democracies. So maintaining that trust was important, not just for our elimination strategy, but as we transitioned to our vaccination program. And there were a couple of things we found with the latter. The first was, as with childhood vaccination, there will be a large proportion of the population who accept the explanation, the evidence, and the importance of being vaccinated. So I talk about that as the sort of the 70 to 75% of people who are waiting at midnight on their computers to book their appointment, and they crash the system at 1 minute past midnight. Of course, then there is another group who do require some extra effort to ensure that services are readily accessible, and, for example, that they can go just down the road or on the weekend or in the evening to get their vaccination. And then, as we find with childhood vaccination, and we know this from our own efforts to increase that over many years, that there is a group that, for a range of reasons, will not take up the opportunity at the first pass. That it requires often a number of interactions with people who they trust. They might have a lower level of trust in government and in health services based on their prior experience. And often it would take 4 or 5 or 6 interactions with, for example, a Māori health provider or a Pacific health provider to build that trust. And because of that, it would require a high level of resourcing to ensure that we got that last 5% that was critical, not just to protect those individuals and their families, but actually to get our population levels up to over 90% and as close to 95% as possible. Now, all these things play out already in our healthcare system, but the vaccination program through COVID just again highlighted these things and also showed that the importance of agility and of trying different approaches was equally important through the vaccination program as it was through the response itself.
Great, thank you. Juliet?
Yeah, maybe just following on from that, there were some nice studies done on trust in science around the world too, and certainly during the early stages of the pandemic. In New Zealand and Australia, trust in science went up, which was great to see. Putting my black hat on for a second, I suspect that average trust went up, but maybe the population polarized somewhat. And I think that's an area that we could really work on before the next pandemic, is to unpack while the average is lifted, which is fantastic. We really need to think about that group that doesn't trust and started to trust less rather than more, which we saw all around the world in various protests. So I think there's a piece of work to do there to really understand how to lift everyone and take everyone on the journey. And at least if people choose not to be vaccinated or not to trust science, they don't see it as such a threat. It's a choice. I think there's some work to do there that globally we haven't done yet.
Can I stick with you, Juliet, on a question about, because I really appreciate your clear approach, and you've mentioned it in your opening comments, rigor, inclusivity, transparency, accessibility. How do you think the dissenting scientific voices which emerge over time, how to bring in that conversation in a way that might help with trust? How do you approach that even now as you perform this role of chief science advisor?
Yeah, I think there's 2 very different scenarios, one when you're in a crisis and one when you're not. So if we're not in a crisis and I'm just going about my job, I try and bring in as many voices as I possibly can. Jacinda will tell you that my reports are far too long. So there's always a long report which tries to capture all voices, and then a short version which synthesizes those. But making people feel heard and really recording all the different perspectives, I think, is a useful tool. In a crisis, you don't have time to do that. And it was remarkable to me that on the day we locked down, I remember switching on the TV and waiting for the dissenting voices, which I often see as a healthy sign of an independent scientific community. And there were none. And I almost had my stopwatch on to see when the dissenting voices would pop up. And I didn't necessarily think that was a bad thing. think something to think about really hard is at which point in the crisis it helps to have that debate in public rather than behind the scenes. So Jacinda mentioned it had been a hard few years. One of the other crises we dealt with was a volcanic eruption, and that was a real short, sharp crisis. And in that case, there was a very healthy community of dissenting voices behind the scenes, watching the volcano and trying to work out what might happen next. And then they came together with a set of public messages, and that was perfect for a crisis. COVID, of course, was a long, slow crisis. And at what point you say, all right, it's not really a short, sharp crisis now. It's a space where we need to bring in that debate, I think is an area where we could do a lot of thinking and some work, because that's the bit where we lost some people and where the polarization started to start. And you can imagine a scenario where the scientists could be supporting that conversation rather than all being sort of stuck on one side of it and the others being the anti-scientists. So certainly something that I think quite a lot about, how we could do that transition from the crisis state to something that's going to be more enduring.
Yeah, thanks. So to switch topics a bit to global solidarity, by 2021, a lot of the United States had received a dose of COVID vaccine, but the wealthier countries had purchased all the vaccines or most of the vaccines. And so in the continent of Africa, less than 1% were vaccinated, while I know I was almost ready for my booster. This is something that we need to really think about for the next pandemic. How, as a leader with responsibilities to your nation, do you grapple with these challenging issues? And you mentioned about your concern about the Pacific with New Zealand as a gateway. Can you talk a little bit about how we should be thinking in the future about these agreements and accords?
I'll be brief, because I think Dr. Bloomfield's particularly well placed to speak to this question. But one of the approaches that we took was we saw ourselves as having almost family-like responsibility to work together with our Pacific Island neighbours to support vaccine rollout in our region, because we saw ourselves as not individually being safe until we were collectively protected. And so there was a very direct relationship with our Pacific Island neighbours in both the sharing of vaccine and the sharing of support, whilst also acknowledging that there was always going to be trust issues. And so we needed to make sure that, in those conversations around supporting rollout, that it wasn't a situation where New Zealand was coming in to vaccinate other populations. That would not be appropriate, and nor would it be successful. But how we could support domestic health workforces, or indeed if we had volunteers within the New Zealand health workforce who had familial ties to the Pacific, to go and support those rollouts, and I think that was important. One thing I would say is that, in New Zealand, we were politically criticised that we received our vaccines later than other parts of the Western world. And it's true, we did. We went in early, we made our play for purchase, and so I certainly don't think that there was a failing of our procurement process, but I do think a judgment was being made that for those countries who were not losing citizens, and we were not, because we had an elimination strategy, the decision was made, of course, to roll out to those who were, and that is totally understandable. But I think whenever we're working on this, how do we ensure this global solidarity, we have to keep in mind the domestic political pressures that exist everywhere. And how do we satisfy both? Now, I, for one, had no problem standing up and saying in New Zealand, we are blessed that our population is not dying. But that does mean that we will be using public health measures for a period of time. But that is a difficult scenario to place on people. We need to remember, we are not safe individually until we are collectively safe.
Thank you. We are soon to be out of time, so what I'd like to do is go around to each of you.
Sorry, I just did what I did for like 2 years to Dr. Bloomfield, where I said he's going to answer the question, and then I didn't hand over to Dr. Bloomfield. So I apologise for about the 100th time. Sorry, Dr. Bloomfield.
Well, what I'll do is go to Dr. Bloomfield first,
Please.
and then Dr. Gerrard, and then back to you for the last word, if that's okay. So, Sir Ashley.
Thank you. And just to add a comment or two around that particular issue, this is the time when we need globally to sort out the issues of more equitable access to not just vaccines, but medical countermeasures. in my role co-chairing the review of the international health regulations, and we're seeing it play out equally in the INB process on a pandemic accord. Rightly, the developing countries are raising the issue of this inequity and wanting a much greater level of assurance in black and white that there will be more equitable access to vaccines, but also medications, personal protective equipment, and so on. And we have the opportunity, particularly regarding vaccinations, to address that now. And efforts are already underway, well underway, including more dispersal of vaccine manufacturing. But there needs to be a really strong commitment to technology transfer, to capability and capacity building. And in a pandemic, in almost no other situation, or in these outbreaks that go beyond countries' borders, it is clearly in everyone's interests for us to do that. And so now is the time for us to really address that. It's not easy. This is a huge challenge in the negotiations that are underway. And since this is my chance for a final comment, just two quick things. One is just to reiterate that importance of trust and the importance of, a bit like prevention in the healthcare area, we need to focus on continuing to build and nurture and maintain trust in our healthcare professionals and also in science. And one thing that has been good to see is that, again, the global surveys show there hasn't been a drop in trust in scientists. They are, in fact, still the most trusted group in society, even higher level of trust than taxi drivers and neighbours. So that's something to, welcome. But finally, of course, we must continue to think about what can we learn from by comparing between what countries did, but even within countries. If you look within the USA, different states had very different outcomes, and really be curious and open to identifying what were the key factors that did ensure that there was a good or a better outcome in certain places. And I do want to just go back to how important good leadership and decision making are, and determining a priori. What is your leadership approach? What is your leadership framework? How will this work? We do this in other crises, particularly military security crises, and there's no reason why we shouldn't determine that and practice it during peacetime. Thank you so much.
Thank you. Juliet?
I guess one thing that hasn't come up in the conversation, except Ashley hinted at it at the beginning, is that we knew we weren't ready. And I think understanding that we weren't ready for COVID-19 was a major driver in the way everyone responded. So as a country, we'd all seen the index. We all knew we weren't the UK or the US. And there were various elements of our system that looked weak, but that actually gave us an impetus to scramble. And as a country, we scrambled really well. Everybody pitched in. So I guess sometimes people talk about everyone being super prepared for the next pandemic. Whatever it is, it probably won't be like the last one, and we probably won't be ready. So back to that humility point, just understanding that we can put all the pieces of the puzzle in place, but we're going to need to accept the fact this is new, and we might need to do something different, drawing on all the evidence that we've got.
Last thoughts?
Oh, some parting thoughts. As I was listening to Juliet just now, I was thinking about the moment where we changed our strategy. And initially, we were really adopting that same frame that you'll remember. Everyone in the beginning was talking about crushing the curve. And I remember talking about, crushing the curve until Juliet one day came up to see me on the 9th floor. She'd just come out of a meeting where she'd been talking with modelers in New Zealand around what the most likely scenario would be for New Zealand's experience of COVID-19. And she presented this graph. She asked to see me. I sat down and she just put this graph down in front of me that she'd only just been discussing moments prior. And it had on it the infamous curve that we were meant to crush, and then a dotted line that just sat through the middle of the page. And I remember saying to her, the dotted line, what is that? And she said, that's our hospital capacity. It was well down beneath that curve. And so immediately it was obvious to me that if we adopted that strategy, I was accepting that people would die. because our capacity to cope with the number of people who would be gravely ill was severely limited. We were not prepared. But actually, as we soon learned, you could have the best hospital system in the world and be overtaken by COVID cases if you weren't adopting other measures. And so that was the moment for me. Now, you know, how was it that we could sit down and have a conversation with either Ashley and Juliet and pivot an entire nation's strategy? Well, it was because these were not new individuals to me. We already had a trusted working relationship together. And I think we need, as political leaders, to think about these issues in the same term with our public. We cannot suddenly come to a crisis and expect that our public will trust our response and have faith in our response if we have not worked to build trusted relationships prior to that point. And so I'm really here speaking to the wrong audience in that regard. But as politicians, we have work to do. It's telling that the last time we lost public trust was during a global financial crisis. People look to politicians to meet their basic needs. And those basic needs are sometimes economic and they're sometimes health. In fact, those two issues, as this room knows, are quite closely linked. But we need to do a better job in between crises of building public trust so that when crisis comes, people are willing to see that one graph and understand that we need to do something significant together. So that's our challenge. And for what it's worth, I'll continue to repeat that wherever I have the opportunity. We were not a perfect response, by no means. We have a lot to learn about how we build trust and how we maintain unity, particularly when conspiracy theories and disinformation is a growing challenge. But we are blessed to have expertise like yourself. Let's build trust in that and trust in our politicians again.
Thank you. Well, Time magazine said that you, Dame Jacinda, gave a plausible case that kindness was a strength, compassion was actionable, and inclusion is possible. And so I would like to thank you and your team, Professor Sir Ashley Bloomfield, Professor Dame Juliet Gerrard, and the Right Honourable Dame Jacinda Ardern. It's been my pleasure. Thank you.
So good morning, everybody, and thanks so much for joining us. I'd like to start out by thanking the Right Honourable Dame Jacinda Ardern for a really terrific launch to this symposium, together with the panelists, her colleagues from New Zealand. So what we'd like to do today with this first panel is to define actions that we can take now to facilitate pandemic preparedness in close coordination among global organizations that are working on this particular topic, and to define what each can contribute to pandemic preparedness and what concrete steps can be taken in the near term. We'd like to begin with introductions. I'm one of the moderators, Bruce Walker. I'm co-faculty director of the Massachusetts Center for Preparedness, and I'll pass it on to Nancy.
I'm Nancy Sullivan. I'm the director of the National Emerging Infectious Disease Laboratories at Boston University. I just arrived here this year after 23 years at NIH working on pandemic pathogens.
Great. I'm Richard Hatchett. I'm the CEO at the Coalition for Epidemic Preparedness Innovations, or CEPI. CEPI is an organization that has a mission statement that says that we seek to accelerate vaccine development against epidemic and pandemic diseases and to assure access to those products for the populations that need them.
Morning, everyone. I'm Daniel Bausch. I'm the Senior Advisor for Global Health Security at FIND in Geneva, Switzerland. I think the best way to describe FIND is as sort of a CEPI for diagnostics. And we work very closely with Richard. I'm an infectious disease doctor, has worked in public health applications of outbreak response with WHO and US CDC and a number of organizations over the last 20 or 30 years.
Yes, I am Jean-Jacques Muyembe. I am from Democratic Republic of Congo. I am virologist, and I was involved in a lot of Ebola outbreaks at the origin and today. So I am like a discoverer of the virus and also co-discoverer of the treatment with monoclonal antibodies from DRC, we call Ebanga. And now I am also in charge of COVID surveillance in my country. Thank you.
Good morning. My name is Cristina Cassetti. I'm the Deputy Director of the Division of Microbiology and Infectious Diseases at NIAID, which is part of the US National Institutes of Health. And our institute has been one of the lead agencies in the last 20 years to respond to a number of outbreaks around the world, including Ebola, Zika, and most recently influenza, of course, and most recently COVID-19. So we have some programs that we have set up to respond to these outbreaks, and I'm looking forward to the discussion.
And we have one person joining by Zoom. Jeremy, do you want to introduce yourself, please?
Yeah, thanks very much. I'm really sorry not to be able to join and with some young friends on the panel then. Jeremy Farrar, I'm now, as of 6 months, 3 days, 2 hours and 3.5 minutes, the Chief Scientist of the World Health Organization. Prior to that, I was head of something called the Wellcome Trust based in London. And prior to that was 18 years living in Ho Chi Minh City, Vietnam, as head of a research program at the Hospital of Tropical Diseases in Ho Chi Minh City, Vietnam.
Great, thank you very much. And Nancy, why don't I turn it over to you?
Thank you, Bruce. So I want to start by thanking our panelists and the audience for attending, and then maybe we can spend a moment to frame this session. So we heard from the Prime Minister of New Zealand, how they managed COVID-19, probably still PTSD, but perhaps less than in the US, after almost 3 years of still dealing with this. So we are all looking at that as, oh my gosh, it was a huge failure and we didn't prevent a pandemic. I think we need to look at some of the things that we did right to help us come up with actionable, concrete items for what we can do in the near term going forward. So what did we do right? We had a diagnostic within a week. That's pretty impressive. We had a potential therapeutic in about 140 days. And then we had licensed effective vaccines in under a year. That's precedent setting because vaccines typically take a decade or longer to develop. So there were things that we did right. I think we all recognize that we probably need to do things faster if we don't want to have another 3-year pandemic, to prepare ourselves for pretty much the unknown. It's pathogen X. And how do we do that? Multiple organizations across the world have been grappling with that question. And in 2021, the Prime Minister of the UK challenged the G7 members to form a group to come up with ways to accelerate this, to make it even faster than 300 days or 150 days. And they called it the 100 Days Mission. And that was challenging us all to put surveillance measures in place, diagnostics, non-pharmaceutical measures such as contact tracing and social interaction, as well as vaccine and therapeutic development, and do that in 100 days. I think we've seen not only this UK group, which comprises Gavi, WHO, CEPI, Wellcome, and others. Around the world, people are trying to do the same thing. And the question is, A lot of that process is aspirational because it takes years to put these processes in place. In fact, some of the milestones for the 100 Days mission are out in 2026. So if pathogen X comes along tomorrow, what do we do? The other thing that we're thinking about is many are taking a priority pathogen approach, and that is, can we identify what pathogen X is going to be? And just use our best guess from what we know about viruses and virus transmission. And there's a framework that lists pathogens in order of what we call priority. There are more than 250 human viruses that we know of, and more animal viruses. So thinking that we can prioritize may be a little bit audacious, because what's happening now is with the priority, people are all working on the same thing. So for example, there are probably half a dozen Nipah vaccines, Nipah virus vaccines. How do we cover that grid of 250 viruses better and now? And what can we do in the very near term concretely to take action? And I'm going to turn this over to Richard Hatchett to ask him if he'll start us off with addressing that.
Great. Maybe just before jumping into that, let me just offer one thing about CEPI that I think is unique is that we are an internationally situated organization, but we are very narrowly focused, right? And I think that makes us unique. All we think about is the epidemic and pandemic problem, but we think about that from an international perspective, and we don't have other issues that we have to allocate our attentional resources to. And so to answer your question, Nancy, coming out of the pandemic, a couple of quick reflections. The delivery of vaccines was faster than it had ever been, and not fast enough. And the distribution of vaccines as a life-saving medical countermeasure globally was faster than had ever been achieved for any prior medical product in terms of the speed of global distribution. And yet equity was not achieved, fairness was not achieved, and the aftertaste of the pandemic for billions of people was very bitter. And so in talking about the 100-day mission, how do we quickly move forward and make progress against that? And I will just say that sitting where CEPI sits internationally and having the kinds of conversations that we have with partners around the world, with regions around the world, I think there are four important trends that make me optimistic that we can make progress quickly. Two I would describe as institutional, two I would describe as technical or scientific. The institutional opportunities emerge from the fact that there is now an enhanced focus globally because of the inequities of vaccine distribution on the geodiversification of manufacturing capability. More manufacturing capability, more widely dispersed, and most of that capability is seeking to secure the rapid response capabilities that were first validated during the pandemic. The second institutional trend that I think is really important is that countries around the world are now valuing having institutions dedicated to medical countermeasures development and production. Many of you may be aware of the organization BARDA, which was the US organization focused on medical countermeasures development and really was undergirded Operation Warp Speed. The capabilities that BARDA had really coupled with the Department of Defense's capabilities enabled Operation Warp Speed, and countries around the world are looking at that model and now are trying to set up their own BARDA-like organizations. So Europe has set up HERA, Italy is setting up something called Biotecnopolo, Japan has set up SCARTA, Singapore set up PredVax. This is even happening in countries like Senegal, Brazil, Indonesia, India, and elsewhere. So you're going to have an institutional capability that is distributed that hopefully could rapidly scale. On the scientific side, I think there are, or the technical side, let me start with the platforms that were validated for the first time during the pandemic. We now have a number of rapid response platforms, most notably mRNA, but not only. viral vector platforms, subunit protein platforms, VLP platforms that were validated for the first time against COVID. And that creates a distributed technical capability to respond rapidly. The last thing that's really critically important, and Nancy and Cristina and others, Jeremy, have really contributed to a intellectual concept around how we can move away from priority pathogens towards developing generalizable vaccine design solutions for viruses in different categories. And this has been framed up as thinking about different virus families and how to design vaccine solutions that can be generalized across genera or even across families. And the proof of concept for this was COVID, because of the work that the Vaccine Research Center at NIAID had done to think about how to modify the spike protein to make it more immunogenic, more visible to the immune system, using MERS as a prototype pathogen, not a priority pathogen, but a prototype pathogen. And then they rapidly adapted that to COVID when the sequences were released. And the VRC and Moderna, not to steal Cristina's glory, but the VRC and Moderna were able to take the sequence information and design what became the first generation Moderna vaccine, I think within, Hamilton Bennett's here, I think within 36 hours, which is extraordinary. And so the idea of taking that concept and expanding it to the other virus families is critical to thinking about how we prepare to respond more rapidly in the future. And Jeremy may want to talk about some of the work that WHO is doing to sort of lay out a normative scientific agenda around the virus families. That's coming. That'll be out next year. And then I think there's an opportunity using those institutional resources and using this convergence around an idea to rapidly make progress. And I think one of the reasons I was thrilled that Nancy and Bruce and MassCPR put this conference together is that the people in this room, in all four of those areas that I mentioned, are very close to the center of an international web. On the technical side, on the scientific side, on the institutional and governance side, the influence that the community gathered here can have to advance this project is tremendous.
Thank you, Richard. And Jeremy, since you were called out, I'm going to kick it to you and also ask you who would lead this? Because if we truly want to bring everyone together across the globe, how do we manage that?
Thanks very much. And yeah, leadership comes in many different guises and very many different forms. And just picking up a few comments from Richard there. So I share. Remember, I'm British, so I have a little bit less American optimism than some of you in the audience and on the panel might be. I have to say I'm a little bit more skeptical that we're quite where we need to be, and I'll come back to that. So I absolutely agree with Richard. Scientifically, enormous progress. Where I would probably diverge a little bit is that this notion that COVID vaccines were developed in a year. Yes, we did those last steps in a year, but they were built off 2 or 3 decades. The Nobel Prize was awarded for work was done, I think I'm right in saying, in the last century. And unless we build that continued, sustained scientific infrastructure, then I don't think we would make the progress that we've made. And I think moving away from this sense that we could make vaccines again in a year without investing beforehand is just would be a mistake. And by investing beforehand, I mean not just as Richard rightly said, and I absolutely agree with you, the families, the platforms, the safety profiles and all of that, but also other things, trust in society, the logistics, the delivery, and picking up the lessons from COVID, but they were not the first time we learned them in COVID. The center of gravity shift that Richard talks about in technology, I think is underway and is thankfully, I hope now unstoppable. But we're going to have to think how we integrate that into sustainable functions. You can't just turn a factory on in any country, including the United States, when you need it. It's got to be functioning, because functionality in a factory depends on having great people. And if those great people are not working with quality assurance and quality control, and there's a regulatory pathway, there's an ethics profile, etc., then you won't sustain them. So one of the challenges, I think, is with all of the new technologies that are becoming available, how can we make sure outside, arguably America and maybe China, how can we make sure that in other countries, in distributed way, those capacities are sustained over time and supported over time to do things that are important every Monday, every Tuesday, every October, every November, rather than thinking it will all be there in a crisis. Because I think most countries can't sustain those things for just the crisis times. They have to provide utility and value all of the time. On who should lead this, I mean, and this is a view, I hope, from WHO, but it's also my personal view. I think WHO has a critical role. It has a unique mandate, 190 plus countries. And I think it needs to be seen, in my view, at the center of the web that Richard talks about, and doing what only it can do, but then facilitating, encouraging, and making sure that others with other skills, basic science, the work of CEPI, the work of FINE, the work of NIAID and NIH, etc., and all of the people here in the audience, that you do your work, and WHO plays the convening, facilitating, and I would argue that's an active leadership role, but doesn't necessarily try to do everything. I think if it tries to do everything, it won't have all the skills. We don't have all the skills in WHO, we can't have. And we're much better to use the total global resources, but then make sure we argue for the coordination, trying to avoid duplication where we can. We make the case for equitable access, both to the science and the benefits of the science, the sharing of information, the data through the WHO Berlin Hub and other entities. So I think that's WHO's role. The viral families is a key element of that, and the WHO R&D blueprint deserves great credit. But then it's acting like something of a conductor of an orchestra, where the key players are the people in the orchestra, and WHO plays that convening role. I think that's the most constructive role WHO can play. Over.
Thank you.
Great. Maybe a little bit along the same lines. Clearly, we're going to have to build capacity and coordinate in terms of being able to develop vaccines for prototype pathogens. Cristina, what is your organization doing along those lines, and can you explain that?
Sure. So, as I said before, we for the last 20 years, we practiced responding to outbreaks for a number of them. And after the last one was before COVID-19, the last big one was Zika. And I worked with many of you in the audience to accelerate development of vaccines and other things. And the more times we do this, the more lessons we learn. So in 2017, our director then, Dr. Anthony Fauci, tasked a small group of us to develop a pandemic preparedness plan, which is basically what do we know, what lessons have we learned from these responses, and how can we do the research response better and more effective. So it's been published in December 2021, is online if you want to look at it, but basically it's based on is a three-pronged approach of what needs to be done during peacetime to be better prepared. One of them is increasing surveillance activities to really understand what happens, especially the animal-human interface around the world. What are the infectious diseases that they're percolating and we need to pay attention to? So really early warning, it's the first pillar. The second pillar is to compress the timelines that it takes to develop a countermeasure, so vaccines, diagnostics, and therapeutics, after the identification of a new pathogen. And the way that we approach this is how Richard mentioned, that through the prototype pathogen approach, we have pre-identified large viral groups from which is most likely that the next big outbreaks will come from. So we're going to do research during peacetime that will develop the knowledge to develop vaccines and therapeutics and diagnostics for any members of that viral family. So we pick some prototypes to do research, and we develop basically the roadmap for how you develop vaccine for a related virus if something had to happen. And the third pillar, which was also mentioned, was to build the infrastructure that you know you're going to need if you had to respond to another outbreak. So clinical trial networks, field sites in different countries where these emerging infections occur. Strengthening diagnostic capacity, and our colleagues here will probably talk about that. Developing better animal models, adjuvants, vaccine platforms. This is all disease agnostic tools that you're going to need, and biocontainment laboratories. We're going to have this set up ahead of the next outbreaks because we're going to need them to respond. So to address each one of these pillars, we launched, and we're still launching, large research programs to strengthen these three areas. In December 2020, we awarded the CREED network, which is the Centers for Research in Emerging Infectious Diseases. And this is a network of research sites in endemic countries all over the world, usually in the tropical and subtropical areas of the world. And we have now awards in a footprint in 35 different countries, and they're going to do some research at the human-animal interface on these emerging infections to try to understand how they emerge and also get a sense of what is circulating at the same time. So they're not really focused on surveillance, but as a byproduct of this research, we're also going to get a sense of what's circulating. To address the second pillar, which is compressing the timelines for developing a product, we issued a large funding opportunity, which is being reviewed actually in the last few days, and we hope to award in March of next year, which is called the Revamp. And this is a research to develop generalizable solutions to make vaccines and monoclonal antibodies against a number of viral families that have been identified as these high-risk families. We excluded purposefully orthomyxoviruses and coronaviruses because we already made very large investments in this area. So we focus on the other viral families for which we haven't made historically very large investments, and we still consider them at high risk. So I think that even if we're putting substantial investments in this area, none of this can work. It takes a tremendous amount of resources. So this can only work if we build strong partnerships across the board internationally. We communicate, cooperate, and collaborate as needed, and just pull in the same direction during peacetime. And then even maybe most importantly, we need to keep in mind what the end goal of all of this is, which is equitable access to these countermeasures to the people that need them as soon as something happens. So we just can't keep track, and that is really the end goal. So I'm looking forward to discuss more how we can do this better.
Mm-hmm. Thank you, Cristina. So I think these are all very important goals and missions, and I like the idea of collaboration, and that builds into what Jeremy said for this network, and Richard, where we fan out but group together so we're pulling in the same direction. Recognizing that each of those things, building factories, doing research, takes time. I wonder, and I'm going to direct the next question to both Dan and JJ. Dan, if you could take it first. I wonder if someone gave you a bucket of money today, what you would do tomorrow that is something you can do very quickly. Yep, go ahead, Dan.
Tough question.
Yeah.
And I'll look at it and answer, I guess, through a find and diagnostics point of view. But to set that up, I guess, the technology's been incredible for vaccines, for diagnostics, for a lot of things. I do feel like we're perhaps overconfident in what the technology can bring us sometimes, and it's not anti-technology, but technology needs to be situated globally in people who can use it and get the maximum benefit from it. And I think we often lose sight of that, and that was really our challenge, of course, with COVID, right? We had great technology, and you cited the diagnostics and vaccines came up, but we really weren't situated to get those to the people who needed them in a timely fashion. So we have to recognize that. There is, in the diagnostics element, there is a particular technological breakthrough that I think has the potential to really be a sea change. And that is really thinking about multiplex diagnostics that are coming down in price and applicability and getting beyond for pandemic prevention and preparedness, a binary sort of thing that it's, something happens and we need to check and see if it's, SARS-CoV-2 or not, or it's Ebola or not. And really we have capacities to implement that are probably getting there to be robust and cheap enough that we can put in place around the world. And so what we really need, and Jeremy mentioned this, I think already, or alluded to it, and he always does, but maybe I'll get to him, get it first this time, Jeremy. But it doesn't happen with parallel surveillance systems. It doesn't happen, and I've seen this a million times. There's an Ebola outbreak and people set up surveillance for Ebola. But these things are actually relatively rare. And so you'll see that they set it up and people test, say, great, everybody who comes in with a fever, if it's negative for malaria, do the RDT for Ebola or do the RDT, whatever it is. But once the outbreak is over, you do 500,000 or 1 million or whatever, and they're all negative because these are relatively rare. And after a while, people say, why would we continue to invest in that? And it takes a lot of time for healthcare workers. And so, the only way for true surveillance, and there's not really anything that exists in pandemic surveillance, it's really disease surveillance, and it needs to be integrated into surveillance for all the common stuff. And so that can't be an extra test that takes more money and more time, but some of these multiplex strategies actually can get you, the parlance that we often use, the horses and the zebras, right, can get you the horses that a test is done every day because it diagnoses the malaria or the dengue or the things that people want to know, that a patient, a healthcare provider, a surveillance officer want to know those and invest in that on a daily level. And then the 500,000th test says, oh, look at that line came up for the rare thing that we want to know, and we actually catch the first case. And so then we can contain. But unless we set up that system, that's going to be very difficult to do. And so, the challenge of that is to set up a system on a very grassroots level. And, I'll also remind that despite the interest in, and it's, again, I'm not anti-genomic surveillance or anything, but the true surveillance signals come from the classic stuff. It comes from the epi signals at a primary healthcare level or from the community that recognize patterns of cases. And so we have to be able to react on that level. So coming back to your, to answer, if I had a pot of money, I would really try to put that in place where we have a system at a very low level of the healthcare system with multiplex diagnostics. So people say, we want to do this every day because it helps us to know whether we need to treat the patient with anti-malarial or whether it's dengue. And then the same test has the potential to get the rare thing that we want to know about very early on.
Yeah. JJ?
Okay. So my institute is the National Institute of Biomedical Research. It was founded in 1984. It is the public health laboratory of the Ministry of Health of DRC. At the beginning, its human and material resources were very limited, but in recent years, the NRB has experienced considerable development in terms of infrastructure and human resources. The NRB has laboratory with different BCL2 and BCL3 security level, different sequencing platform. In 1998, I was the only PhD. But today, we have around 30 PhDs of international level. This great harvest is because 80% of researchers trained in European, Japanese, and American university return to NRB, where they find almost the same research environment. When they return home, they have a career perspective. Here are the achievements of the NRB. The DRC, because of its diverse ecosystem, is contributing to understanding and control of several diseases with epidemic potential, such as monkeypox, Ebola virus, and so on. To deal with this, the NRB has developed capacities for surveillance and response to epidemics by developing reference laboratories dedicated to the detection of epidemics of common pathogens, such as poliovirus, measles, yellow fever, and so on. By conducting surveillance of biological samples from wild animals, mainly bats, in relation with the viruses of Filoviridae and Coronaviridae families, and from wastewater in relation with poliovirus and SARS-CoV-2. By using innovative strategies in terms of diagnosis, therapeutics, and vaccination as responses to the overlapping of Ebola outbreak and COVID-19 in 2018-2020. In terms of diagnosis, we use GeneXpert platform, usually used by the National Program of TB Control. This was introduced as PCR rapid test for both Ebola and COVID-19. In addition, genomic sequencing was integrated in the Ebola outbreak response to better understand the chain of transmission and to detect the COVID-19 variant of concern. Sequences of Ebola virus and SARS-CoV-2 are shared with GISAD international platform. In terms of therapeutics, in 2018-2020, the NRB and NIAID and NIH conducted a clinical trial for Ebola therapeutics under difficult circumstances under the PALM 001 protocol. PALM is Pamoja Tulinde Maisha in Swahili, and it means together save life. The FDA approved 2 antibody-based therapies, Ebanga and Izimat, as a specific treatment against Ebola virus disease. Note that Ebanga was initially developed in collaboration with Dr. Nancy Sullivan when she was at VRC at NIH. Since then, PALM-RST was become a multi-partners clinical research program at the NRB. Its objective is to strengthen capacity to conduct clinical trials on emerging and emerging diseases of public health interest, and also to develop a warm base of infrastructure and qualified personnel for use in various studies, and to establish governing structure to guide partnership and define clear procedure for review of studies and protocol. So PALM is now our tool to train researchers for clinical trial. And we have implemented recently PALM 006, PALM 007, and PALM 008. So this means that we have experience to conduct a clinical trial during outbreaks. And this is a very good mean for the preparedness, for pandemic preparedness. And also during this period, we conducted clinical trial on 2 vaccines, the Merck RVSV-ZIBOV-GP vaccine and the J&J vaccine. Merck was used like a ring vaccination at the epicenter of the outbreak, and J&J vaccine was used in general population outside the epicenter of the outbreak. And very recently also, we conducted a clinical trial with J&J vaccine in Equatorial region, often affected by Ebola virus epidemics. And at INRB, we work in a team, in a multidisciplinary teams comprising researchers and social science specialists, including psychologists, sociologists, and anthropologists, and communicators, in order to associate scientific realities with the socio-cultural realities of a new disease. Having a new efficient vaccine is one thing, but having it accepted by communities is another thing. So to conclude, I think at the INRB, we succeeded to have a transfer of technology, and the team is always vigilant and ready to respond in case of outbreaks. And so this is very important to have in Africa, to develop a leadership for research, for surveillance, and for response, a local leadership, a strong local leadership, and also to develop a relationship, a partnership with our partners around the world. And if we have money, I think the first thing will be to strengthen our health system and also I think to develop a kind of vaccine production, and also a PPA, protective PPA, personal protective equipment. This is very important. For example, even for gloves. Gloves are imported. Diagnosis tests are imported. So that is the kind of thing we must have, we can produce locally as a pandemic preparedness.
So it sounds, JJ, like you're reiterating what Jeremy was saying about local capacitation and how important that is and how that has really helped INRB step up and respond. I'd like to turn it over to Bruce.
Yeah, so thanks very much, JJ. Another question that we'd like to come back to is the issue of the intersection between multiplex diagnostics and syndromic surveillance, and really how we should be thinking about that. And maybe Richard, you could start, and Dan, you could make comments about that.
Well, just very briefly, I mean, diagnostics is not my area of deepest expertise, but I would say that if you look globally during the pandemic at the places that succeeded best, at least in the early stages of the pandemic, they were places that were able to implement diagnostic strategies very, very rapidly and to move quickly into testing and tracing and efforts, as Dame Jacinda mentioned, towards containment from very early in the response. And I think that was the point that you were getting at with the multiplex diagnostics. And to come back to JJ's story, which is really for those of you who haven't been to DRC or don't know INRB, it's really inspiring how that institution has expanded under JJ's leadership. The reversal of the brain drain, the growth of capability to rapidly diagnose and respond effectively to diseases like Ebola or Mpox, and it speaks to the importance, one, in terms of any response, having the diagnostic capability, and second, having that diagnostic capability, as JJ was saying, being locally, situated and effectively integrated into healthcare delivery. And I'll maybe turn it over to you and Dan.
Yeah, thanks. I think, and I don't want to oversimplify multiplex diagnostics. There's a lot of things that need to be worked out there, but nevertheless, I think a couple key points. Where I often see a lack of interest in investment is at the lowest level of our pyramid of the health systems. And that's, I think, for a lot of different reasons, because it's a tough place to invest, right? The technology, the benchmarks, they say, okay, we're doing this project in R&D and we're going to have these tools. That's relatively easy for people to buy into. It's relatively easy politically for politicians to buy into, because you can say, look, I created this. When you say, okay, we need to shore up the primary healthcare system, that's pretty difficult, right? Because the benchmarks are not so obvious. There's no real end in sight to it. It's not as conceptually, for a politician to buy into that, but it's nevertheless somewhat ironic, because I think it really is the base on which everything else has to be placed, and in many places it's crumbling, and so that's a huge challenge that we have to face. It also, if we're starting with diagnostics, I think, of course, for pandemic preparedness, what we're most concerned is respiratory disease, because that's the thing that really threatens to spread around the world very rapidly. And people used to ask me what was the scariest event I was ever associated with, and they expected me to talk about Ebola or Lassa or Marburg or other terrible viruses that I've been involved with in outbreaks. But my answer, at least before COVID, was it was the influenza outbreak of 2009. And recognizing that, we saw that very, very early on in northern Mexico, and it came up through into California. And then, despite knowing what it is and despite having diagnostics relatively available globally, we completely failed from preventing that virus to just circulate throughout the globe. And we were relatively lucky that it happened to be not a particularly virulent virus. And so I just want to come back that, these elements of the medical countermeasures are super important, but we knew, the politics aside of like how long it took us to know what was happening in Wuhan, but nevertheless, we knew about COVID and SARS-CoV-2 for a good while, but still had a hell of a time really trying to control it, right? So it's not all about diagnostics. We have to remember that we are not prepared in terms of response, regardless of even if we knew right away what the pathogen is. So the diagnostics and early warning, extremely important, and obviously we want to contain it so our task is not so difficult that we get the first cases rather than finding out when it's already spread. But we have a lot of work to do in terms of response capacity.
And maybe I could just ask you how close you think we are to the reality of a multiplex diagnostic that's affordable and that JJ can have for surveillance.
So it already exists. You can already buy a relatively small thing. I wish I brought one with me, but and there are various diagnostic companies and making these that sit on a desktop. It's about this big, and for probably cost, depending upon what the market is, for $300 or $500 for the machine, and then a 7-plex assay can be as low as $5 or $10. But that's, so that exists. There's still a huge, a lot of work to do in terms of developing the use cases and how that gets put in place, and also coming back to kind of that base of the healthcare system. If you don't have the capacity actually to use that information, if you say, okay, well, now we know that you have TB, but we don't actually have anything to treat your TB or the other elements of the healthcare system, so it gets pretty big. The technology is there. We need to do a lot of work in trying to figure out how to use it. technologies there in terms of the testing. The technology is growing, of course, and this is part of the whole paradigm is the digital connectivity, right? And so we can use that basically to try to eventually feed into diagnostic systems for early warning. The genomics comes later. The genomics tells you what your real problem is once you have the early epi-signals that can be digitally reported. So there's an incredible capacity, and I think the real technology and the real promise is that it does cover the zebras, but it actually has incredible capacity and potential to cover all the daily stuff, right? And that's what people are most worried about. Despite all our concerns about pandemic preparedness, it's the daily stuff about the malaria, the dengue, and things like that that people are really grappling with. So if we can fit that into those systems and approach those things, we kind of kill two birds with one stone. And I think that's the promise of really a sea change in the diagnostics. But we have a lot of work to do. Over to JJ, I think.
Yes, I think the other issue of preparedness is to involve the frontline doctors and nurses. These personnel will detect a new phenomenon in the community and alert the epidemiologists and virologists. If these people are not involved in our training, it will be the epidemic will be detected
late detection.
Later, it will be that will be the problem. I don't know if there is physician, doctors here in this room. Most of you are epidemiologists, virologists, and so on. But we are neglecting the frontline personnel. That's very, very, very important to detect very early a new phenomenon in the community. And for the multiplex tool for the diagnostic, it is important also to adopt to adopt another approach, not only a single pathogen, but to take into account the symptomatic
syndrome.
A syndrome.
Yeah.
The syndrome, respiratory syndrome, hemorrhagic syndrome, and after that you can process for multiplex analysis. It is what we are suggesting as a preparedness, as a pandemic preparedness.
So I'm hearing some themes from the keynote, and that is starting at the lowest level and having humility. I think when we get into technology and the highest level of research, we think that we can control things. But what I'm hearing really, and I think I've heard you say this, Dan, is that a pandemic doesn't start as a pandemic. It starts as a single case or a cluster of cases. And to really get ahead of it, we need to have the systems in place at the lowest levels, the primary healthcare workers, to complement what we're doing at NIH and CEPI and in other places. So Cristina, I'd like to ask you, keeping in mind the necessity for a network, as Jeremy said, how do we make that happen in the near term so that the research happens, which a lot of times we're thinking about the research, but we also do something pragmatically for the syndromic surveillance and diagnostics?
So the approach that we at DTM&H, so first of all, it takes like a village, right? So we at the NIH are really focused on the early translational side of research with the idea of generating concepts for vaccines or ways to stabilize glycoproteins that can be then transferred to some people that develop vaccines professionally, like pharmaceutical companies, and then people that actually test them in the field. So we occupy the earlier stage of R&D. So we did repeat. I forgot what you just asked me. What did you say? Sorry? Can you please repeat the question?
Yes, so how do we integrate the surveillance, the diagnostics,
Yes.
and the clinical syndromic surveillance into this bigger research plan? Because NIH's mandate isn't to go out and do, primary care surveillance or diagnostics.
Yeah, no, that's a great question. So in the way that we developed our research program at the NIH, we're not tasked at the NIH to do surveillance per se, but we did establish this CREED network to understand at the local level in these countries at the human-animal interface, the mechanism by which some of these viruses emerge by human behavior or destruction of the environment and all of that. So we're doing some of that research at the local level through this CREED network. And then in parallel, we are developing these generalizable vaccine solutions to be ahead of the curve and develop concepts for how you make a vaccine. So we're not very good at predicting what is going to come next. I mean, we tried many times, and we always don't get it right. So we decided to kind of take a step above. This is the work that you and Barney did, and then many of us joined, Hillary and I and others, to how do we implement the concept of generalizable solution. And we landed on studying, looking at viral families as a whole and figuring out ways. For example, we did that worked out for COVID-19. The reason why we were able to respond so quickly is because of 20 years of research ahead of time by Barney and others on how you stabilize the glycoprotein of coronaviruses in a way that you get a very good immunogen. So we were lucky that COVID-19 was caused by coronavirus because we knew how to do that for that viral family. We don't know how to do that for several other viral families that are of concern to us. For example, bunyaviruses or some paramyxoviruses like Nipah and Hendra and others. We're kind of behind, so we're trying with this new program that we're launching, this revamp, to bring all these other viral families up to speed to the point where if anything happened in that space, at least we have the knowledge that we need to respond quickly like we did for COVID-19. But we need early warning systems. It takes a village, right? We need people that do surveillance with good diagnostics in the ground. And in parallel, we're trying to develop these generalizable vaccine solutions for also monoclonal antibodies because we're not sure what is coming next. So that's the approach we're taking.
Thank you. Go ahead, Richard.
No, just wanted to also toss in an idea. We haven't really talked about it because a lot of the discussion around diagnostics has been focused on clinical diagnostics or clinical surveillance, which is critical, and obviously capacitating healthcare workers at the ground level is going to be critically important. But one of the interesting outcomes of the pandemic were explorations of new technologies and the potential application. I mean, wastewater surveillance most prominently, I think, either in particular settings in schools, airports, or more pervasively and continuously. I think people are beginning to envision how we could have continuous disease surveillance systems, not necessarily for diagnostics or clinical diagnosis, but for understanding what's happening in a community over time. And I think that kind of orthogonal thinking is going to be really important if we are really to move to systems that allow us to jump on new pathogens and start using our prototype knowledge to rapidly develop new capabilities. And I think the concept that I would want to suggest is that there is a lot of research into understanding how these new really novel approaches might be employed or deployed. And I think there's one sort of outstanding economic question that we also need to think about, which is that a lot of the discussions that we've been having have all been envisioning effectively government-financed systems of production of countermeasures, of production ultimately, or funding of healthcare system strengthening. And health security as a problem is more pervasive than just government-funded programs. It can't just be, funded through governments, or we're not really going to be able to sustain the capabilities that we need pervasively and continuously in perpetuity. And there are, I would just offer as a kind of something for you guys to think about. We have all kinds of security problems. We have national security problems, and we create militaries to address national security problems. We have fire security problems. I mean, cities used to burn down. I mean, Chicago burned down 152 years ago. And over time, over centuries, actually, we have developed systems that distribute the cost of reducing fire risk throughout society. And it's handled by insurance mechanisms and building codes and government-funded fire departments and a variety of other mechanisms. But we found a way to distribute those costs across all of society so that they can be borne. And we have not figured out this problem of pervasive surveillance yet. We have not figured out how to bear the cost of the health security challenges that we face. And we need not just clinicians, not just virologists, not just our industry partners, but we need economists and we need social psychologists, and we need to be thinking really creatively, because this is a problem that is constitutive to modernity. I mean, this is emerging from the society that we have built, and it's an escalating, accelerating risk. We need to figure out how to pay for this in a sustainable way, and it's not going to be something that governments can do by themselves.
Yeah. Go ahead, Dan.
Well, first of all, I'm impressed that Richard knew that Chicago burned down 152 years ago. He's very exact on that. That's impressive. But I want to second that point that we really do need to think of creative financing mechanisms. In some ways, they're actually equally or more challenging than the technology. And so, through CEPI and vaccine and development and find and diagnostics and NIH, we can probably create the right tools. But then, who buys that tool and who maintains that tool? So we had discussion as monkeypox kind of hit the scene last year in a bigger way. Colleagues from Institut Pasteur de Dakar and Diatropics, that's a small diagnostic production facility on the grounds of the Institut Pasteur in Senegal. I mean, I said, so should we produce a monkeypox vaccine or a monkeypox diagnostic test? And so, it's a good question, and now everybody's thinking about monkeypox, but then, it's one thing, the production, but how does that maintain, right? Who's going to buy that test and for what price? It's probably never, Ebola, monkeypox, they're never going to be maintained by a user, right? It's not going to be a fee for service that people are going to say, okay, I'm coming in and paying for my Ebola test or my monkeypox test. And so, we have, especially with emerging diseases and pandemics, we have these huge waves where you need it now. But then after that, often you don't need it for a while. And so keeping that warm base and production facility is extremely important. And the other point I wanted to make, because I fear we'll be out of time, and I was talking with Cristina last night, and I said every public speaking engagement that I do, I always mention something about human rights, and I'm going to mention it again here, because I think we just need to recognize, and especially in this context, so the human right to health is an extremely important part of it that needs to be built into all this. And then I'll put that in the context here for universal health coverage. And because even if you put the moral and ethical things aside, a sick person who doesn't have access to care, right? We don't have the ability to know what they have to treat that individual, but we also don't have the ability to know if they're the first case of SARS-CoV-2 or the first case of some new pandemic-prone pathogen. And so really ensuring that people have that access to care, not only for ethical reasons, but for strategic reasons, is extremely important.
I think those are important points that go back to some of the comments that JJ made, that it has taken him years and years and years to build up that healthcare capability in the Congo. And really, it's almost an experiment in itself for how he's managed to engage primary care, primary health care, deliver healthcare to more people. And I guess I would like to ask this panel, is it really audacious to think that we could do a similar experiment with some of the things that we've suggested today? So if we agree that surveillance needs to be agnostic to really detect something, we've got the genomic wastewater sampling, we've got multiplex sampling, and then we've got the ability to engage local communities and their primary healthcare workers to do the syndromic surveillance. Is that something we could actually test to see if that's going to help us detect things ahead of time? Go ahead.
I'll jump in. I think it is something that we can test, and I think part of being prepared, besides embedding our preparedness in day-to-day systems that function, which is critical. I mean, you can only surge what you practice all the time. While I'm again not expert on the use of wastewater surveillance or other or these integrated diagnostics or surveillance techniques, one of the things that CEPI is very self-consciously taking on and thinking about how to do is how do we do, in the term that we've borrowed from our colleagues in the Department of Defense, our live fire exercises. How do we actually test the systems that we will need to perform in an extraordinary way when we need them to perform in an extraordinary way, building on the day-to-day capabilities, but actually, probing those systems to see how fast can you stand up a clinical trial and deliver safety and immunogenicity results? How fast can you manufacture clinical trial material against a novel pathogen? And that takes investment, and it's on for the kinds of things that we're thinking about, on the order of at least tens of millions of dollars, but that's what we were set up as an organization to do. So we've been entrusted with funds. We're going to go out and find ways to actually really test those systems. And I think, ideally, maybe this is overdefined, our diagnostics colleagues, but we need to be doing exactly the same thing with the same kind of integrated approaches to early detection. And if we imagine a world where we actually can successfully detect early, use maybe in a more refined way than the sort of blunt instrument of lockdowns, but use our non-pharmaceutical interventions effectively earlier to reduce transmission and geographic dispersion, and then deliver countermeasures much more rapidly, it actually moves us into a world where we can prevent pandemics. But that's only going to work if we can test all of the elements of that system. So.
Yeah, you said, what was it, audacious to propose that? Answer yes, but I like audacity, so that's okay. I think I'm still looking, and there are groups in the world who are pursuing this. I mentioned Senegal. Senegal has quite an advanced surveillance system that they're trying to put together. But I do think, I still haven't seen in what we need to define is what does success really look like for a broad program. And then try to, as Richard said, it needs to go beyond what does success look like on a piece of paper. Can we really test this out? Some of it you can test out in reality. You can't test and see whether you picked up an Ebola virus or SARS-CoV-2 because the chances of it being introduced at any one time are low. But nevertheless, I think trying to figure out how, at least on a small scale, how we can really create an image of success and see what worked and what didn't work. And ideally, some of this would have to be tabletop models and things like that. It's probably not all going to be reality, but I think trying to think this all the way through from routine surveillance and then, okay, now we catch something. How quickly did we catch it? In the meantime, did we do some good in catching the other stuff that we want to catch? And then how rapidly can we put the right now diagnostic in place that would probably be initially PCRs and then go through to RDTs and things like that, using the genomics to learn more about it. How rapidly can we pivot from the things that Richard and CEPI are doing on that particular vaccine? Okay, can we get that in place? And it's probably not all going to be real world, but I think a better, clearer image of success would help us a lot. And even if we started in one place. And I don't want to say that, there aren't, there's tons of work going on in the world that's furthering this, but I think trying to put it all together in a little bit of a model and figuring out where we were ready and are not ready would be very helpful.
Maybe we can also hear from Jeremy on this issue about that you've just been talking about. Jeremy, do you want to comment?
Yeah, sorry, not to have come in before. I would like to shift it though from the abstracts of the models. Pandemics are quite rare, but epidemics are common. And actually, CEPI was set up to deal with them, as Richard rightly says, and deserves enormous credit, for instance, for the contribution recently to the chikungunya virus. But whilst we must focus on disease X, the reality is, whilst we're waiting for disease X, maybe tomorrow morning, but maybe in 100 years, there are a lot of other things where we could work in concrete terms, not abstract, to deliver good things that would then come out of them. So take Nipah, take Marburg, Lassa, Ebola indeed, take flu. Are we confident today that we would have the MPIs in place with the societal trust if there was an H5N1 pandemic tomorrow? Do we know what drug to use, in what dose, in what delivery device? Do we need combinations to prevent resistance at the start? How quickly would we actually have an H5N1 vaccine that could be delivered around the world? The same questions, JJ, huge work on the Ebola, but there have been multiple other Ebola outbreaks and we haven't delivered that concrete action. So I would rather we move from the abstract sense of let's try and model this to saying we have outbreaks of these, Lassa, Marburg, Ebola, Nipah, seasick flu regularly. Why don't we use those as the test beds that allow us to do what we're talking about and actually at the end of it, deliver a diagnostic test that works and at scale and is cheap, delivers a therapeutic that we know works, and delivers a vaccine that we know we could manufacture at scale, and we know that we would have the MPIs. That would also deliver things for communities that are faced with these sorts of outbreaks all the time. It is what CEPI is doing and trying to do around Lassa in West Africa. I would like to see more of that concrete actions, whilst also considering what happens if a true disease X hits us all quickly. Over.
Thank you very much. So I think we're actually coming to the end of our time. I think we want to thank all of the panelists. What we really like to do is come up with action items. And maybe just very quickly, a few words, we could hear from each of you about what your takeaway is in terms of what we should do now in terms of action items that will put us in a better place in terms of pandemic preparedness. We'll just start down here. Richard, do you want to start?
Oh, okay, I was going to hand off.
He was trying to pass to me.
Yeah. Very briefly, because we're at time.
I think Jeremy's concept of using real life test beds, that was kind of what I was getting at, doing real life exercises to the extent possible, thinking how to integrate these systems.
Yeah, I mean, I think there's probably not one approach, but Lassa is one that we already, through CEPI, through FIND, through a lot of different groups, are already doing a lot of work in, and something that's, this isn't a good thing, but you know that there's a fair amount of transmission, and so you can interact there without looking for the needle in the haystack. Not always the easiest places to work in terms of some of the issues going on in the endemic areas, but you know that might be an area to start. Yeah.
JJ?
Okay, I think the next pandemic pathogen will emerge in Africa. So we have to strengthen the health system in Africa by increasing the capacity to detect early the epidemic, thanks to a group of clinicians, well-trained clinicians, to recognize the disease very early, and also to increase the capacity of confirmation in the lab, and also their capacity to conduct clinical trial on therapeutics and vaccine, and to share data with an international platform by sequencing and so on.
Thanks very much. And Cristina?
Yeah, no, I think this is the time in between pandemics when you build these bridges of communication and coordination, because if something had to happen, chaos erupts and you only go talk with your friends, people that you already have links with. So this is the right time to develop this kind of bridges and connections to make sure, we all have access to certain expertise and certain things that we can do best. So if we could figure out during this inter-pandemic time how we can best integrate all these efforts and have open communication channel communication, I think this is the best thing we can do at the moment.
And Jeremy.
Final word, Jeremy, you can wrap us up.
So by the end of the decade, the list of viruses we've heard about, we know how to diagnose them. We have a therapeutic option, which we know is safe and works, and we have a vaccine available that we could manufacture at scale for the things we know about, and we haven't ignored disease X. But I think the things we know about will be more likely to be more common, and they'll provide utility to communities all of the time. By the end of the decade, we have them all covered. That's what I think we should do.
Great. Well, I want to just wrap up by thanking Nancy as a co-moderator here, thanking each of the panelists for their time and insights, thanking BU for hosting this, and thanking the MassCPR for really initiating this conference, and all of you for attending. Thanks very much.
Thank you.
Hi, thank you all for joining us. We're going to introduce ourselves in a second, but just wanted to welcome you to the panel. And I think we're going to have a pretty interesting discussion building on what you've already heard this morning. As was just said, I'm Karen Weintraub. I'm a reporter. I've spent the last 3.5 years covering the pandemic, among other health issues. And so, and thanks to Bruce, I felt much better informed during particularly the height of the pandemic, when was not getting a lot of information out of government. So some local experts were feeding me information, which was fabulous. Anyway, moving down the line here, Hillary?
Sure, I'm Hillary Marston, Chief Medical Officer at the FDA. My experience with the pandemic started with the ProMed reports of a cluster of cases in Wuhan. So was involved at NIAID, where I was the Pandemic Preparedness Advisor, had a chance to work with Cristina, Cassetti, Nancy Sullivan, among others, National Security Council, and the COVID team on the global donations. So I got to see various aspects of it, but now I'm at the FDA for the regulatory role. Thanks.
Hi, NEIDL. I'm the director of the Boston University Center for Emerging Infectious Diseases Policy and Research, and my experience was being a frontline clinician here at Boston Medical Center, and I ran our special pathogens unit that took care of some of the first patients that were admitted to our hospital and helped the state as well as our hospital deal with those responses. Also part of a lot of the state planning as well as some of the conversations internationally in terms of communications in particular, as well as serving as the NBC medical contributor for a couple of years. And then last year, I had Hillary's job. I was at the White House, the Senior Policy Advisor for Global COVID Response, working on donations as well as what happens as the emergency phase ends for COVID-19.
Hi, everyone. Raj Punjabi. My perspectives come from having first served as a physician at Brigham and Women's Hospital and in the Mass General Brigham system during the first year of the pandemic. I was involved in some of the COVID testing, community outreach sites, and vaccination sites. I was also leading a nonprofit called Last Mile Health, which was working with the African Union and several countries in Africa to expand access to PPE and tests in that first year. Another role that I was playing at that time in 2020 was to work with President Sirleaf, former President Sirleaf of Liberia, and former Prime Minister Clark of New Zealand to stand up the WHO's independent panel for pandemic preparedness and response, which is a mouthful, I admit. But its goal was to critique the global response. And so it went from critiquing governments to then being asked by my own government here to serve in the Biden-Harris administration. I just spent 2.5 years working first on one of our oldest pandemics as the president's malaria coordinator, leading something called the U.S. President's Malaria Initiative, and then was asked for the prior 1.5 years to work at the National Security Council at the White House alongside Dr. Marston and Bedelia here to I was leading the pandemic office at the National Security Council there, where we focused on both global COVID response along with the COVID response team, but also on helping prepare the nation and the world to prevent and prepare for the next pandemic.
Hello, everybody. I'm from Rwanda. And in my previous life, I'm a retired grandma. In my previous life, I learned a lot by running the National AIDS Control Commission, where everything was about community for prevention and also for welcoming and help people affected by the disease. This has helped me a lot when later on I became permanent secretary and minister of health in my country, because scientists, they're all there. We even doesn't have to have them at home. A phone is enough. But the community and how to deal with the community, to protect the community, to avoid rejection, stigma, etc., I learned a lot by managing the National AIDS Control Commission. So now I'm retired, but before that, I have built a university where we teach people that firsthand. Because a doctor, a nurse need to partner with politicians, with local leaders, with the community leaders for protecting the population in period of crisis, but also on the day-to-day life to help everybody to create the right legal framework, the right connections to be all together ready the day we need to be ready. Thank you.
Good morning, everyone. I'm Robbie Goldstein. I'm the Commissioner of Public Health here in the state of Massachusetts. I came to this pandemic, like so many others, as a frontline clinician. I'm an infectious disease doctor by training, worked at Mass General Hospital. And then about 2.5 years ago, I took a leap and went to CDC as a senior policy advisor to then Director Rochelle Walensky. Spent a lot of time embedded in the incident command structure at CDC, thinking about the public health response to the pandemic and working closely with the director on the communication and the messaging around that.
And I'm Emilio Amini, and I'm going to start back in 2015 when I joined the Bill and Melinda Gates Foundation after 32 years working in the biopharmaceutical industry and vaccine development and antiviral drug development. And at the Gates Foundation, I was the foundation's global head of the HIV and TB programs of the foundation, and was in the middle of all of that when the COVID pandemic showed up, in which case most of that work stopped, except what we did is that we took a lot of what was going on in our HIV and TB programs and adapted them to the response to COVID. I was then seconded to HHS in the US government for about 6 months when the Biden administration came into the White House. And then about 7 months later, I took on my current role as head of the Gates Medical Research Institute, which is located right across the river here in Cambridge. And the purpose of the institute is to work on the development of interventions for diseases for which the capital investment is not necessarily there. And the reason I took on that role was because of the learnings that what I saw was not present in the response to the COVID pandemic. And that was also not present for many years in response to endemic diseases. So we took on some of those efforts at the Institute.
Thank you. And I'm Lindsay Baden. I'm As already mentioned, and as JJ in the previous panel mentioned, I'm an infectious disease physician, clinician. I think my most important contribution has been caring for patients with COVID. In fact, 44 months ago, I received an N95 mask, which I still have. And we forget what it was like in 2020 in terms of what was available, even here at our most resource-rich environments. I also am an investigator and played important roles in the development of certain countermeasures, particularly the mRNA 1273 vaccine, the Moderna vaccine. And I'm an editor at a journal, New England Journal of Medicine, and for the last 15 to nearly 20 years, have sort of watched global events to try and understand which of these we should be concerned about and should highlight. And as the previous opening remarks and the panel one, at what point do we care? And this panel, what we would like to focus on, and I think Prime Minister Ardern mentioned it, the last panel talked about it, communication. And perhaps the greatest success that Prime Minister Ardern had was communicating, and we saw with her team how complicated that was and how they continued to modify their approach to engage their community and to bring their community along in the response. And that challenge is still before us. So the themes for this next hour are the need for speed, democratization of information, which means science in real time, and observation anywhere is known everywhere. And during this meeting, those of you in the audience are ahead of us on the stage because you're able to monitor what's going on in the world, and we are not. That is how fast we are communicating. Communities are not monolithic. And as JJ pointed out, as he is a native French speaker, and we take for granted the language we use to communicate, and at moments he needed a little assistance to find the right word. I marvel at his ability to communicate, but we forget something as basic as language, as interacting with how we communicate. Where does reliable information come from, and how do we incorporate that? And ultimately, the five-letter word that has been, I would argue, the theme for today and the theme for the pandemic is trust. We have limited information, changing in time, and those out there who may misuse information. And how do we bring along each other in all of our different communities to understand a pandemic and how we respond? Along these lines, and we will have a series of questions that Karen and I will ask our panelists, probably asking two of you to primarily respond, and then have a discussion about the issues at hand. And the first question I'd like to ask to you, Emilio, and to Raj, as Hillary mentioned, it was about 48 months ago where some of us monitoring ProMed, thank you, Larry Madoff, and that in December of 2019, November to December of 2019, there was this weird cluster of idiopathic pneumonia. Eventually it was Wuhan pneumonia, and eventually a pathogen or a putative pathogen. Koch's postulates are hard to fulfill in the modern day. When we see a pathogen, we've talked about Zika, SARS 20 years ago, dengue, Mpox, but when do we know that we should be worried? What are the characteristics in December of 2019, January of 2020, of the syndrome and the virology that should alert us that we should pay attention and be worried? How do you think about that? And then to Raj, to build, will be how do we then as a community respond and have an initial response?
You know, the easiest way to answer the question is like, we all process information, we all process things that we learn in the context that we already have, all right? If it's out of context, you will not understand what you've just been told. So it's very important to have that. So I'm going to tell a little story here very, very briefly. So actually, it was at the end of February 2020. So where was I? I was in all places. No one left, please. I was in all places in Disney World. I was in Disney World down in Florida with my wife, and I had just come back from Seattle, in fact, at the beginning of the month, all right? And I'm reading on my cell phone, sitting at dinner. I actually remember exactly where I was sitting at dinner, reading on my cell phone, and I was reading about the outbreak that was going on in the nursing home, as you recall, that was right across there from Seattle. So I had the context of Seattle. I knew exactly where the nursing home was because, in fact, we had just had an off-site of my HIV group literally half a mile from where the nursing home was. And I'm reading this, and given my context and having worked on infectious diseases for almost 40 years by that time, 35 years, it was pretty clear what was going on and what was happening, to the point where I then looked out from the restaurant. It was on the second floor of this hotel, and I'm looking out, and there was a pool area down there, and there was a gathering. It was a commercial gathering. Some company was having all of its people, come in from around the world. And they're all there, all crowded around, saying hello to each other, kissing each other, and all of that. And I'm looking at it, and I looked up to my wife, and I said, "We have got to get out of here." Okay? And which we did. We left literally 2 days early, okay? So it's like, all right, it's evident what was going to happen. It was just strikingly evident. Now, it's strikingly evident to me, but then how do you communicate that, right? And ever since then, it was the same question, which is, so I go back, Pennsylvania, which is where we were living, just outside of Philadelphia, and how do you communicate to people in Philadelphia what you just saw and put it into the context of saying, we have an issue here, and we have a problem, right? Which became evident to everyone about 4 or 5 weeks later. But again, you need to have people who've got the right context at all levels of society, and very importantly, people who have the trust of individuals who may not have the right context, but which you trust when I say, hanging out in Disney World at the end of February 2020 is not a good idea, all right? And it was critically important to do that. So we've already touched on the issue of the importance of trust, on the importance of the community interaction, but the information has to be processed in the proper context, and that only happens if you've got people who've got the right context to understand the information when they see it.
And along those lines, to you, Raj, you're now in the White House. Your job is pandemic preparedness and response. There are a handful of cases, maybe serious, maybe not.
Yeah.
How do you decide that this is serious and we should now invest the resources? Because investing the resources are really the theme from earlier today.
Well, just to clarify, I was in the White House until August. I'm now a recovering public servant, as I like to think of myself. I also was at Disney World in February 2020. Turns out there was something in common. And to answer your question, I think it was very evident at that time. So evident that when I was working with the World Health Organization, interviewing frontline doctors in Wuhan about what they were seeing, there were doctors on December 27th, 2019, who had sent off bronchial lavage specimens for next generation sequencing at commercial labs, and had just gotten back from 2 different commercial labs at 2 different hospitals, evidence that there may be a new novel coronavirus per the information they got back from the labs. One of the doctors I spoke with was so astute they had a husband and a wife who had both been, it turned out, infected with the virus. They were living with an adult son in their home who had no symptoms. Having lived through SARS-1, she brought the adult son in who had no symptoms and got a chest CT scan, meaning, for those who aren't in the medical field, actually scanned his chest and found that he had evidence of bilateral infiltrate. And when I spoke to her, December 27, 2019, is when she first started to think there may be potentially asymptomatic human-to-human transmission. So I think Dr. JJ was absolutely correct. There is intuition, instinct, practice, wisdom of those on the front lines. And so I think we first look for that. At the very same time, she thought those things may be in place. We didn't necessarily have evidence that asymptomatic human-to-human transmission was actually the case at that time. And that is often the uncertainty we deal with. And so I think there are 3 shifts we have to make in the way we communicate at the beginning of these crises. Number one, and you'll have to forgive me because in residency I could only remember things through alliteration, and I've heard that I'm obnoxious at that. So I think 1 is we need to shift content and the way we talk about it. 2 is shifting the channel, and 3 is shifting how we work, how we engage consumers of that content. First, on content. Science is not knowledge. Science is the pursuit of knowledge, which means it changes. So we have to both communicate what we know, but we also have to communicate what we don't know. We also have to communicate how we know it, and then we have to communicate when that data or evidence may change. So that's the shift in content. Rather than sounding certain, I think Prime Minister Ardern was correct, communicating humility. The second C here is around the channel. We spend so much time in these crises working with national media, with no offense to my friend Karen at USA Today. You know, the trust is higher in local media. And so we've got to spend as much time working with local media, and you can see this in polls like Gallup and the Knight Foundation did in 2021 that showed there was about 17% more trust in local media for Americans here. But we also have to shift out of the digital and television and radio to not only do that, but shift from social media to social networks. We know from all of the behavioral science, when you're trying to help people change, their social networks are what matter most in persuasion. So that brings me to the third C that I mentioned, which is the consumer. I think we have to have more faith that the American people and people around the world are capable of nuance. They're capable of being more scientifically literate. They're capable of being discerning about the information they're getting. And to give just two very brief examples of proof points. In Liberia, during history's worst Ebola outbreak, it's where I grew up and where I had the privilege of serving, including during that outbreak, the Liberian government turned to the communities themselves, these are people without a high school degree, and trained them within several weeks. At the very moment we were told 1 million cases might occur if nothing more was done, that more than half of the people would die, at the very moment in history when that strain of Ebola did not yet have a vaccine for it and people were afraid, when doctors were humbled, nurses were humbled, the president of the country, President Sirleaf at the time, was humbled, he turned to the people who didn't have a medical degree, a public health degree, not even a high school degree, and said, could you be part of our team? And within weeks, they trained individuals on the signs and symptoms of Ebola. They went door to door to find the sick and get them into care because they're of the community. And I know my friend Professor Agnes can speak to her experience in Rwanda around this. Liberia's community health workers helped hunt down the virus and stop it in its tracks. They kept their people safe. They kept all of us safe. But Liberia didn't stop there. They kept that force active, dealing with malaria day in and day out, dealing with complications of childbirth, helping mothers get to hospitals to give births. They were present. They became a community event-based surveillance system, picked up 5,000 potential infectious disease trigger events over the next several years, between 2016 until 2020. And then when they got the vaccine for COVID, those same community-based workers put their vaccine cards on their sleeves. I mean, talk about wearing your heart on your sleeves, and said, look, I got the vaccine. You would be safe getting it too. And Liberia, which still is one of the third lowest income country on earth, became the third country in Africa to get 70% vaccine coverage, which was their goal amongst adults at the time. That's happened in the bright spots of this pandemic, even in this country. I've seen vaccinations delivered in places like La Colaborativa's community center here in Chelsea, when Chelsea was 40 percentage points behind the statewide average and was the epicenter of the COVID pandemic here in the state. And they recruited their neighbors. Thankfully, the Massachusetts Department of Health gave a grant through, I think, passed through from the federal government, not just to the hospitals, but to La Colaborativa and other community organizations to host vaccination sites. They asked their neighbors to go door to door, canvass people, get them registered for appointments, tell them they could get a job because they'd been laid off and how you could get a job, give them mass hand sanitizers. And on that first Sunday in April 2021, We had several hundred people show up for the vaccine in a place where it was said hesitancy would be a problem, and within a few weeks they closed that gap. So I think the way we engage consumers, whether we're in academic medical centers, universities, must be to get involved with civic organizations, religious organizations, community organizations, to do that work of not making communities the objects of change, but the agents of it.
And Robbie, how do you do that at the state level? How do you make that work? It's a great idea, but how do you?
It's challenging. It's challenging work. I think as Raj mentioned, that particular organization got funding through the state at a time when we didn't have an infrastructure to really fund those types of community-based organizations, faith-based organizations, those organizations that have the trust and can continue to build the trust in collaboration with government entities. We are, I will say, in the Department of Public Health now, we're trying to figure out not how can we be reactive to what we saw over the past 3 years with COVID, but how can we be proactive to set up those initiatives that will be ready to go. We're doing that currently through something that's called the Vaccine Equity Initiative. And I've told people, I've been in the job now for 7 months today, and I've told people for all 7 months, it's a misnomer. Yes, we're getting vaccines out, and yes, we're working on equity, but what we're trying to do is a preparedness initiative in our most vulnerable communities. We are trying to make sure that we've defined 20 vulnerable communities here in Massachusetts, that they have the resources they need all the time to respond to whatever may happen tomorrow, the next day, or the next year, and that they're doing it on a daily basis so that trust remains in place. So that when we need to go out and say, here is a new vaccine, here's a new therapeutic, here's a new diagnostic, here's a new disease that we're worried about, they will listen to us, they will engage with us, they'll engage with the community-based organizations. But we are having this conversation before the panel started. It's hard work because this requires constant funding. It requires constant effort. We have our Vaccine Equity Initiative is at this point 100 people strong, which we're really proud of, and they're all funded through a federal grant that will end in January of 2025. And the question is, how do we continue to do that trust building, that communication that's necessary in the absence of stable funding?
I was just going to ask that of Hillary, like, how do you deal with that? Maybe not from your FDA hat, but at the federal level, you know, how do you keep that going, especially with a Congress that isn't necessarily supportive of this at the moment?
Yeah, well, I'm certainly not going to comment on Congress right now. I'll tell you that much. I like my job. Look, the FDA isn't a funding organization, obviously, but for the most part, we have small grants programs. But I think it's continuing to have the drumbeat up that these programs are important. The large majority of the funding goes to wonderful organizations like NIH. They are our largest grant-making organizations. I think that there's been more and more of a recognition across the government that these sorts of initiatives also need funding over time. Would I like to see more resources devoted to this? Absolutely. I think that another part of that is showing the benefits of making those investments. So programs like the one that Robbie is building up are documenting the successes of that, assuming that there are successes, and I have every faith in my colleague. That's going to be essential to proving the case for the next time around.
And Hillary, just to talk about trust in the agency, and you're not speaking for the agency, what we witnessed 3 years ago was a change in how the FDA, how EMA did business to incentivize, allow, facilitate the community to develop countermeasures. Do you have reflections on the trust process that build trust, or things that we need to think from a regulatory frame that will enhance trust going forward? Because the speed with which countermeasures are developed are incredibly important, but dependent on the bar you set.
Yeah, absolutely. So I think we learned a lot of lessons over the course of the pandemic about the ways that a regulatory agency could facilitate development, what we could do in terms of setting out a cookbook or a roadmap for how these things could be developed. So for example, CBER, the Center for Biologics Evaluation and Research, put out a guidance very early in the pandemic about vaccine development. And I know folks at NIAID were certainly looking at that very closely, Operation Warp Speed. I mean, Lindsay, in your study, you were the first to adopt some of that. That was an important lesson that then fed over to the other portions of the FDA. So for example, our Center for Diagnostics and Radiological Health was able to take that and implement it for their diagnostics work. So what did that mean? That meant that they established a partnership with the NIH where they were able to evaluate diagnostics on a steady apples to apples comparison. They set out templates so that the diagnostics developers knew exactly how we wanted to see the data. And they set out standards for what we would need to see in order to offer an EUA. I think one of the things that we forget, a couple things that we forget about walking into this pandemic. So first is that EUAs had rarely been used in the past, right? They had been used for diagnostics in Ebola, a handful of other cases, but really this was a new mechanism, and certainly I don't think most of the public knew what an EUA was. And now I think that we regularly have people correcting others about whether something was approved or authorized. So we've come a long way in our understanding of that regulatory pathway. Number two is how new that some of these countermeasures were, right? So Operation Warp Speed took a huge bet on a number of largely unproven platforms. It was not certain at all that mRNA was going to pan out. If it had not, we would have been waiting months and months for the next vaccine to offer evidence. The US government invested in a huge way and it paid off, but we could have been in another situation. Luckily, moving into future outbreaks, hopefully, I mean, they're going to happen, we now have more experience with both of those pathways. We have more experience with the platforms. So I think we can draw on that in the future. We can point back to our experience with mRNA vaccines, for example, so it won't seem so new to the public, but I think that drawing out those lessons is going to be critical. The other thing as a regulatory agency is we work very closely with our partners at the CDC to make sure that we're getting good content out to the public as soon as we are able to, as soon as we're able to give our thinking on things. That's something that we're doing more work on, and I think we'll probably get into misinformation and disinformation. But how to package information in a way that's readily digestible, I think as public health agencies, we probably make people do too much work at this point to find the information. We need to make it far, far easier to access things in accessible ways.
So I want to do a two-step, a follow-up with you, Robbie, and then building on the earlier concept that Cristina raised of peacetime and wartime. So wrap up the wartime, Robbie, with you, and then open peacetime with you, Agnes. So there you are responding to the wartime, and the analogy, I assume, is we're in the middle of a pandemic, rapid transmission, communities are very uneasy. How do you learn, in this nation, we have 50 states with 50 different public health departments. How do you leverage what's going on in the other states to learn how to do it better here? Is there something there in the trust that they're building or losing in their communities that you think we need to incorporate, or you have incorporated in Massachusetts, that sort of builds on the trust concept from 49 other experiments around us?
It's a great question. I'll maybe start by saying that I'm one of, actually the few, I've learned this, one of the few state public health officials that have gone from the federal government down to the state system. And I think it's given me a pretty unique perspective. Having seen all 50 states from the federal system, I can recognize that all 50 states are completely different. And in fact, every county is completely different. And here in Massachusetts, we have 351 cities and towns, which are all completely different. And so, yes, there are lessons that I've picked up from those in other states. I'd say in particular, folks in New England, we get together on an every other week basis. We talk about what we're seeing. We talk about what's working, what's not working. We ask each other questions. We challenge each other's assumptions. It's helpful. But I also know that Connecticut is very different than Massachusetts. Rhode Island is very different than Massachusetts. And I can't oftentimes do the things that the commissioner in Rhode Island and the commissioner in Connecticut can do. I think where one of the things that I'm trying to do in Massachusetts is to make sure that we're sort of challenging some of the assumptions that are coming at us. Meaning, we oftentimes hear, and all due respect, Hillary, to you still at FDA, but we often hear from the federal government. I used to bring this message out from CDC. This is the guidance. This is what you should do. This is the current state of the knowledge. And we take it as fact. And I actually think it's our job in this state, it's our job my job as a state health commissioner to challenge that, to look at the primary data myself, to understand, is this truly what I want to share with the people here in Massachusetts? Does this apply to the communities across this state? Am I going to be able to amplify that message, or do I need to craft a new message here in Massachusetts for the people that are responding to the Department of Public Health? That's where actually talking to other state health officials is sometimes helpful, because we can all challenge the assumptions together. We can all say, actually, that doesn't resonate with the people in my state.
So as the first session this morning raised, and I think Ashley said it beautifully, we have global amnesia with rapid onset. 20 years ago, there was SARS. So the idea that SARS, a coronavirus, can have pandemic potential, we all knew about it. We all witnessed it. We were fortunate because of certain parameters around it that limited its rapid spread, that SARS-CoV-2 had different properties, such as asymptomatic transmission. A question that we think a lot about and was also raised this morning is the issue of the interpandemic period, the peacetime period, and what do we need to do with our communities to build trust? You know, it reminds me of my Louise and my dear colleague, Paul Farmer, who came up with the concept of accompaniment. You know, how do we have community members who really have the trust of their community and are able to deliver care broadly, and we can build on that. Agnes, as you think about this from the different seats you've had, how do you think about what we need to build in the interpandemic period to build that trust with our communities?
Thank you, great question. And there was a study done just before COVID in 2018 that measure the trust communities have in the health sector of their countries. In this country was 60%. My country, 93%. So they came to me, I didn't even know that the study was going. They say, tell us what you did. And I said, about what? About this result. So we start to think, what have we done well? And what we have done well is to involve the communities all along the way, when there is no problem and when there is a problem. Because it's not when there is a problem that you start to seek trust. You seek trust because the community know how you function. And we have what we call an umbrella. We have a meeting regularly every 3 months under the Ministry of Health, where we have the religious, the youth, the women, the community leaders, the representative of the mayor. So all the leaders that count in the country, parliamentarian. And we discuss about the matters in general, a new law. Is it correct? So that's how things pass like very easily in Rwanda, because we have already consulted all the constituency. So when there is a crisis like that, this team is called at a minute. We call scientists, and I remember we didn't know. I had the phone of Fauci and say, what is this thing again? And I say, Fauci told me that in the meeting. So we need to be ready. How can we be ready? And we have the voice of each and every one at the first minutes. So now, in all churches in Rwanda, Muslim, Catholic, Anglican, and all the others, in all association of women, youth, the same message is already there within a few days, the day after. And if there is change, because for COVID, I remember, we didn't know what it was. And we say in the message, that's the science today of our friends, the people who know what they do. We don't have this level of science at home. But they don't really know what it is. And as it changes, we will send another message. So the population is informed of the flexibility, things change. People who never saw a mask, when we told them you need to put a mask and explain what it is about, but it was explained in the churches. It was explained in the youth association, etc. So the role of health leaders, when you create a system like that, is very easy. You take the scientists, you ask around, you put everybody around the table, and everybody go and give the same message. Harmony. No one was not informed. And with the system of community health workers, now there are 4 in each village for 1,500 people. They give the same message. You have the same message on radio, on TV, at church. Because, when somebody like me go and say this, they don't trust me. They go to their pastor. At Kigali, they say this, is it true? So you better have the pastor say the same thing. Because they will follow the pastor, they will not follow me. So create a system that the community trusts, that are available to the health leaders at a minute, because we don't know what drama will be there tomorrow.
And obviously, today we have to do that in the context of disinformation and misinformation, bad actors.
We have something better. In your country, you can kill people with words. They die, no consequences. Only if you use a bullet, there is consequences. In my country, if you spread words that may kill people, you go to trial. And it's the government who puts you in trial, or civil society. Anyone can complain. So if the science has been proven, you cannot go and say the contrary. Our master are the science.
NIAID, obviously, we're in a different situation here in this country. Talk a little bit about how you get information out, how you build trust in an environment that is where even the leaders can't necessarily be trusted to put out accurate information.
Karen, thanks for that. And let me start by saying trust is not something that's given, right? I think that's been reiterated. It is something that's earned. And Professor Agnes talked about the idea of building that trust. And I think Raj mentioned this as well before an emergency happens. And I want to stress that because, and one of the most important things that came out of the first panel that I want to stress on related to that point of trust is vaccines, therapeutics, and diagnostics are necessary, but they're not sufficient. One of the most important reasons I went into infectious diseases is because there are 2 organisms we deal with, the pathogen and the human, and the complexity of pandemics isn't just the disease itself, it is the competing priorities at the individual level and the government level. It is the complexity of disinformation, but also imperfect channels of how information are shared. It is about the fact that people will see just history of health inequity and say, well, why are you only here for this one disease? Why do you only care about this one disease, right? So I feel like that work about communicating starts much, much earlier. And the way that I sort of think about it is I compare pandemic response or pandemic preparedness to our response to fire. Our response to fire isn't just our fire department. What do? We start with building codes. We alter the way we manufacture things. We have fire insurance. So why is it that when we think about responding to pandemics, we'll only think about the response part when so much of that is baked into the system beforehand? We make people understand the importance of it in the inter-pandemic period. And a large part of earning that trust, both here and in the US, actually both here and the rest of the world, and actually I was in Liberia in 2020 February, which is the same sort of story as what we were seeing here, where there was an anxiety about this new pathogen. You do that by building that trust at baseline by addressing health inequities in communities. That applies to communities in Boston, in the United States, it applies to communities around the world. Professor Muyembe talked about this, right? We live in a world where 50% of the world doesn't have access to essential health services. A Lancet Commission in 2021 said half of the world's population doesn't have access to essential diagnostics for the 10 main infectious diseases. How can you presume to stop pandemics when it's likely we live in a world where we're missing majority of the spillover cases? You build that trust by meeting the rest of the needs of a community and treating them with trust before a crisis happens.
And yet those communities seem to have more trust in their medical system than the people who do have that access.
Well, we have those inequities here as well. I mean, just look at the early numbers in terms of access to vaccinations. Even as monoclonal antibodies rolled out or Paxlovid rolled out, when you look at who had access, the communities with highest social vulnerability were those who were the least likely to be able to access those medical countermeasures to begin with. So I'm just not saying it's an issue globally, it's an issue here as well.
Right. And Hillary, you talked in our pre-conversation a little bit about how Tony Fauci had been the go-to person and then immediately became a target of disinformation and was no longer, in a sense, a trusted messenger, at least not for, didn't unite the community behind him. How do you deal with that, or how do you think we could deal with that in the future?
Yeah, I mean, that was just a horrible, horrible moment for the response when we saw that starting to turn. And the reason why I said that he was the go-to was that he had been, any pandemic that you saw, he was all over the news, right? Like he was doing the full Fauci, he was going around on all the Sunday shows. And even when the administration changed over and we had they had a mini table talk exercise about the things that the new administration might see in 2016. He was at the table, and the advice of the Obama administration was, pull on that guy, right? Like, bring him in. He is one of our best communicators. Get him talking to the public, et cetera. So he was the go-to, and I think for good reason. He was excellent at synthesizing information, drawing on the experts that he had at his disposal, and getting the information out in a very credible way. I think we need a bench, and we had that luxury. I don't think that we probably should have expected, given where this country is, that anything will be polarized. But we needed a bench, and it couldn't just be the federal government, right? So I think that that's what you're hearing here across the stage, but there should have been a broad network of public health and a way to get messages from the federal government, but also to tailor them, as Robbie said.
Raj, you had some thoughts about this also in terms of disinformation and how we counter some of that. Do you want to talk about that a little bit?
Yeah, I think the focus on that consumer of information is something we ought to pay more attention to. And that is partly work we need to do during a crisis. And there are actually exemplars during the COVID pandemic, and my colleagues here have mentioned some of those. Some of the ones I was most moved by were Dr. Bedelia and the COVID response team had organized a summit in the White House, I think it was earlier this year, and it was a COVID equity summit. And one of the University of Maryland professors had worked with barbershops in Maryland to help reduce vaccine hesitancy, but also by engaging barbers who are largely part of the community and had been working on hypertension and trying to reduce rates of hypertension for many years. Again, that theme of using response and preparedness is like a muscle. If you use the preparedness muscle every day, you'll be ready for response. And so they had been using their preparedness muscle on hypertension. But they pivoted and asked those same barbers to help improve vaccine coverage amongst, in that community, largely African-American communities, but especially men. And they were able to close that gap because of that kind of approach. But in between these crises, again, I think we in the university community have to ask ourselves, are we going to continue simply to talk to fellow scientists, to fellow students, to fellow faculty? Or can we look beyond the walls of our universities, of our hospitals, of our clinics, as places like Rwanda have, and build a collaboration with civic organizations, with religious institutions, with schools to deal with improving public health literacy, what a virus is and isn't, what a vaccine is and isn't, and build that kind of capability day in and day out. I think Dr. Goldstein's exactly right. To do that, we're going to need action at the local level, and we're going to need it at the federal level. So many of the pandemic policies that we create are focused on products. And we need more of that, as we heard in the last panel. It has to be more efficient, more effective, more equitable. Sorry for the alliteration again. But we also have to invest more in people. So when Dr. Goldstein's talking about a $3 billion American Rescue Plan investment in 107 jurisdictions around the country's local public health departments, who are a critical node of that local infrastructure we need to reduce mis and disinformation, we've got to think beyond a 2.5-year grant. We've got to ensure Congress puts that into annual appropriations. And so I think there's a whole lot of work we can do, both at the federal level and the local level. But it's got to be work we do. You know, to build muscle, you use it. It's got to be muscle we use every day.
So information, disinformation, there are bad actors, those who may manipulate information for their purposes. There's also, as Juliet mentioned this morning in the opening session, as they were thinking about how to guide New Zealand, they would have a plan on Wednesday and the facts would be different by Saturday. And we saw this in January of 2020. There was evidence of asymptomatic transmission. In March, there was evidence of it living on fomites. We didn't know what this meant. So, Emilio, we were talking this morning about what kind of infrastructure we need so that we can have the trust, we can deal with the issue of flip-flop. I said today, thou shalt not wear a mask. And then tomorrow I say, thou shalt wear a mask. And that erodes the trust because it looks like flip-flopping, with Jacinda told us is bad politically. I don't think it's great scientifically. But we were talking this morning a bit about how we think about what kind of groundwork we need to lay so that information that's evolving that could look like disinformation or be used as disinformation can actually be used properly. And for all of us, we were using information as you did in leaving Orlando, and we all did, to protect our families. So how do we get information to protect those around us, but also to communicate in a way that allows evolutionary information?
It's exactly what everybody's been saying over the last few minutes. I mean, you will trust the information that comes from the person you trust, right? And even if the person you trust says, you know, what I told you yesterday is not necessarily true today, and here's the reason why, you will still understand that, and you will still trust that person simply because you trust the person. And that only happens, quite frankly, at the community level. And it happens, if we just talk about public health, happens with that individual who was responsible for delivering public health interventions to you, you know, for whatever it is, you know, vaccinations for your children, you know, treatments for metabolic diseases and for cardiovascular disease, you know. And the information that comes from the barber is very good, okay, because you will trust your barber, all right? Certainly I did. You would trust your barber, and that's information that you will understand. You know, when we're faced with an unknown situation and where there is a continuous change in information simply because you're trying to catch up and trying to understand what's happening and what's not happening and what have you, quite honestly, the last people that anybody should listen to are the people who are sitting here. Right? You know, no, because you won't do that. You mean, you know, half a century ago maybe people did, but not anymore, right? So you need to build up that muscle, if you will. You need to build up that group of people, you know, and mostly they will be at the community level, whom you trust, okay? And the information has to go down to that level of community level, and then it has to come from them to the actual community itself. There is no other way in which it works, right? And we saw multiple examples of that during the pandemic. We saw it, and we see it, and there are multiple examples of that. You know, I spent many years working in HIV and TB, right? So HIV was a classic paradigm, right, of situation trying to deal with HIV in African countries. All of the communication only worked at the community level. It did not really work at any other level, right? There could be USAID signs all over the place. No one paid any attention to them. What they paid attention to was what your community people, my apologies for that, was what your community people actually told you, okay, and where that interaction was. So in the end, okay, given even the discussion at this morning's panel, you know, we talked about, well, what do we need to do to be ready for the next pandemic? Instead of worrying about the next pandemic, we need to worry about what we need to do today. Because if we get it right today, it'll be ready to go when the next pandemic shows up. And it is difficult to sustain novel manufacturing systems. It's difficult to sustain long-term funding for novel research. We all know that. It's very difficult to be able to do that. All right? But what you can sustain is human capital. When you've got people trained, when you've got people to understand, when you've got people that have the right context, because you just gave them that context, and they can use that context to explain it to others, that persists and will be ready to go when the time comes. Right? Even if you don't use it immediately, it will be ready to go when the time comes. So focusing on that human capital is fundamentally critical all the way at the community level, and building the trust has to be in there.
And building that human capital is who funds it? How should it be structured? And then to Agnes.
It's the old story, right? So you can't build, human capital requires financial capital to build. But the reality is, it's something that, and you don't do it in the context of the next pandemic. You do it in the context of what am I trying to deal with today, okay? I live in Philadelphia, right? So West Philadelphia, many parts of Philadelphia, it's the largest, poor city in the United States, right? Significant issues. A lot of desire to work at community levels. The most that can be done is dependent on the amount of money that's available. But in the end, it's amazing how sometimes the money is found, right? And it's not that expensive to work at the community level. It is important to get people to go out, to train people, for people to come in and be trained, right? But you can get it done, and it is doable. And I would argue, if there's a limited amount of funding available to do all of the things that we talked about this morning and today, I would focus on that, because that is truly sustainable. The rest can come along when the funding's available.
Agnes, you had a comment?
Yes, money is a pretext for doing nothing.
I agree.
And I think for my country is not a big country, but if you take the religious and you train them how to train their people, it costs nothing. They take their bus, they come to the meeting, they take their book notes and they take notes and they go. So we can do that with the religious, we can do that with the youth, we can do that with the women, we can do that with the students, we can do that with everybody. The cost is the cost of giving them coffee and biscuit during the meeting. So, pretext. But just do that systematically with all the stakeholders, all the communities. Same message. And after that, they go, they deliver it. And you can just sit and relax. The work is done.
Yeah. Could I add to that? I think what you're hearing is the importance of community nodes, right, in terms of being able to reach people, which kind of raises the challenge of why, when you look at countries like the United States, there's a huge, I think Vivek Murthy, our colleagues, the Surgeon General, talked about the epidemic of loneliness, right, the social isolation, the digital focus that plays a role in the communities here, which means that people have fewer community nodes to another person, and hence the challenge of pandemic response and information sharing then falls to more central roles, right? Government. Those are the very populations the ones that are isolated are probably more likely to polarization, because they're getting their sources then from not multiple sources in the community, but they're getting it only through online sources. And so even as we think about community organization and trying to make those linkages, I think we have to recognize that there is this other challenge of how to deal with that level of distrust. One thing that I feel like we need to stress a little bit more about is the importance of trust in your political leadership. Jacinda Ardern talked about making these decisive decisions, but what's important to notice is that politicians and policymakers generally in the system, even though there are many of us who might have identified the early signal, the system as a whole has a normalcy bias baked in. When a new crisis happens, people don't want to respond to it until they have a little bit more data. There is a cost to response. There are resources, there are marginal costs, and ensuring that politicians, policymakers understand the importance of potentially making that early move, taking those political risk of acting is going to be an important part of how we, I think, build trust in some of those isolated communities as well.
There is a cost, however. All those politicians have scientific advisors. They pay them anyway.
Yeah.
So, pretext.
Well, Andrew Cuomo struck me, the governor of New York struck me as somebody who did rise to that level early in the pandemic for a while until he was sidelined for other reasons. But he was somebody who was on TV regularly talking to those people in their mother's basements or whatever, who really did reach out to people who maybe who weren't at the barbershops, who weren't reaching that community. So are there does that just naturally bubble up? Do we just wait for those leaders to raise their own hands? Or is there some way to build that, to train the students in public health to be those people when these crises happen?
Professor Anias and I were talking about this earlier. So the new Global Health Security Bureau at the State Department has this program where they're going to try to do a lot more training on health issues with folks with missions, particularly as having them serve as advisors for the ambassadors and others who are there. The role of scientific advisors to policymakers cannot be stressed enough. How do you get those leaders to arise? Actually, you train them. I think there's plenty. Somebody talked about how, I think it was Richard, talked about the importance of economists. And I think there's a role for teachers, for trainers, for those who actually train others in governance, for this to be included in that. And then the role for scientific advisors that are nearest to power to have to be have the ability to influence them.
I might also argue that there's a role for media.
There is a role for media, Karen, absolutely.
Primordial role of media, because people trust more what they read in the bad newspaper than what is said in Washington. So the media is crucial and so much neglected.
Thank you. I appreciate that.
But the media, given the change in the platform, we get our information so differently than 20 years ago. In fact, it's pushed to me by the communities that I already look at. Mm-hmm. So do these echo chambers make this worse?
Well, of course they do. And they do make them worse. But again, remember, people believe what they hear, what they read, whatever the case happens to be, because it fits into their pre-existing context, all right? So the only way to deal with that is to speak to whomever you're speaking to, but understand the context of that individual, all right? And that's how you cast your message, understanding the way that individual is going to accept your message, right? So I mean that's pretty well known. But in the end, again, it comes back to a relationship that needs to be established between the person giving the message. And I realize this sounds simplistic, but between the person that's giving the message and the person receiving the message. And it's critical that that be there, okay? And sometimes it takes a while to build all of that. But then that comes back to the overall issue of building the muscle on both ends, okay? Building the muscle on the end of the people who give the message so that they learn how to give the message, but also to get the people who receive the message trusting that what they receive actually is something that they should actually listen to and understand. That takes a lot of work, but we live in a society now where that is fundamentally critical, and it needs to be done. It needs to be done at all educational levels, okay? Starting with people much younger than the people in this audience, right? To actually be the group that goes, as a matter of fact, myself personally, I go into high schools. I go into high schools to start delivering the message. Once you're out of high school, it's too late. Okay? It's too late to change people's context. You need to do it at that high school level, right? And that's where it has to be. And even younger levels than that, all right? And we live in a society where that becomes fundamentally critical. Or otherwise, we will always be susceptible to the misinformations.
Why don't we now take 2 minutes each and sort of summarize what you think, we know, as we said, there's going to be another pandemic coming at some point. What do you think we can do better the next time? What do you think we should be doing now to make things better the next time? Do you want to start?
Sure. So we've talked a lot about the importance of building trust over time, right? And largely in the context of being ready for the next pandemic, that's what we're about today. But look at what's going on right now in the United States. We are losing life expectancy. It has been happening for the last few years. If you control for COVID, if you control for opiate use disorder, we are still losing life expectancy. So why is it? It's common chronic diseases, and we know how to treat them. We can build these networks now in a way that is useful for public health and deserves that sort of investment. So I think we need to be doing that now. we could also put this to work for things like the opiate epidemic. I think these are things where if we have too much of a pandemic bias, we are going to lose the opportunity to build that trust, to build what we need for the future.
So Hillary and I joked at the beginning of this that we're twins, and it's not just because we held the same job not too long ago. But so I was gonna make that point, so I'll just agree with her. I think that's important, and it's very important because there's an IMF study from 2 years that shows that in the aftermath of most major epidemics for 5 years, what you see is an increase in Gini coefficient, which is income inequality. And often we ignore recovery, and recovery is a good time to build that trust. So I'll make that point. But the other thing that I wanted to point out is pandemics, epidemics, outbreaks break us along known fault lines. And in the US, part of the issue is our public health system is in the public area sector. Our healthcare system is largely in the private sector, and the two are kind of separated. I wish there were better seamless connections between the two. There aren't as many, but now is the time to be able to do that. One is because many times, a lot of these private organizations, healthcare settings, need to build resilience and surge capacity at a time where there's already overwhelmed hospitals. And so if we want to build that capacity now, we have to sort of help hospitals, healthcare systems remain open, have surge capacity, and part of that surge capacity is healthcare workers. Yes, many of our healthcare workers came back, but when you look at the experience in West Africa, I was actually a frontline clinician, as was Raj during the West African Ebola epidemic. You see that healthcare workers who've been through that trauma, they're gonna have a harder time getting involved the next time. In our country, most of the world's healthcare system and healthcare workers have gone through a lot of trauma. I can tell you that by experience because at the beginning of the COVID-19 pandemic, first few months, I had PTSD to my response to the West African Ebola epidemic. And I can tell you that most clinicians who are now going to be facing the next threat will think back to their experiences to these last 3 years and go, is it going to be worth it for me to stay in there? And so we have to build that surge capacity for healthcare workers as well.
I would just add to the good points that have already been made that the word concept public health starts with the word public, and investing in communities, as we've heard again and again on this panel, investing in communities is an antidote to the plague of mistrust in public health. And one of the things we can all do is get behind the policies that don't just invest in new products, but invest in people. And there ways to get this done. Nationally, the Centers for Medicare has just published a new rule that would, and I know everybody's read it already, it's about 2,000 pages long if you're looking for a good doorstopper, but embedded in there is the nation's commitment for the first time to reimburse community-based providers. These are patient navigators that are helping defeat hesitancy, if you want to call it that, around colon cancer screening and breast cancer screening. They are community health workers and community organizations like La Collaborativa who are helping improve the diagnosis and management of patients. That's the kind of policy we got to get behind nationally. And globally, we've got to do that too. 6 million women on the front lines of healthcare go unpaid or underpaid every year. Those are women that are embedded in communities around the world. And I'm very proud that one of the things the administration did, we got behind, was something we'd passed at the President's Malaria Initiative. For 15 years that program's existed. We invest $800 million a year in 30 countries to defeat malaria. 40 countries plus have eliminated one of our oldest pandemics in humanity, malaria, on the backs of these workers. But when I went into the government, there was a policy that said you can use this money to pay for bed nets to protect people from getting mosquito bites, mosquitoes infested with malaria. You can pay for medicines. You can pay for tests. But you shall not pay for the workers who deliver those products. Yeah. And we reversed that policy. 15 years old, we reversed it in 3 months. And that's both exciting and outrageous that it took that long and it was an administrative decision to do it, but we need to see a lot more of that around our local, national, and federal policies and global policies.
So we know who are the targets. Those are the people in the community. You speak the same language, it's English. And you just have to go and speak to them. So create the system that make it systematic. Not when there is a crisis, not when there is a pandemic or an epidemic, a systematic way. And talk about health in general, among the Black community, the problem among, etc. And when there is a pandemic, focus on a pandemic. But don't come out of the blue because there is a new virus.
I will echo what everyone has said already. I think one thing I want to just lift up is implicit in our conversation today has been this idea that we're talking about unidirectional information, getting information down and out into the community and the importance of community health workers and community engagement for that. But I think to prepare us best for the next pandemic, to get us in a better place, we have to think about bi-directional communication. I'll throw out the example of Barnstable County, which many people in the audience were engaged with the outbreak in Barnstable County of the Delta wave. And having a community that had trust with healthcare, a community that had been engaged with healthcare because of HIV exposure, HIV risk, that was willing to participate in the system, willing to participate in public health, gave all of us on the stage the information we needed so that we could take the right action. We see this time and again, we saw it with MPOX, the rapidity at which we were able to take action at a federal level because we had a trusted community sharing information with us. We're seeing it right now with Xalazine and the drug supply all across this state, where we're hearing from people who trust public health and are able to share information up. And so when we're building these systems, investing in the people, it's the bi-directional flow that I think is most important to prepare us for whatever might come next.
To add to that, when I talk about women, youth, etc., they not come from the top in Kigali. They are elected at sector. They elect their people, and we take their representative. So they are answerable to their people, not to the national level.
And just to synthesize between what was said this morning and this afternoon, and going back to just the common theme as we talk about what do we need to do to be prepared for the next pandemic. Look, there are a lot of technical things that one can do. They all require substantial financial investments. Sustaining a lot of the things that were recommended is very difficult to do as well because it requires sustained funding and sustained financial investment. But the one thing that always does work is if you build your human capital, all right? So it comes back again to human capital, whether it be frontline community workers, all right, whether it be people who know how to run a factory that actually makes vaccines, whether it be someone who knows how to develop a new diagnostic. Building that human capital is critical. And it's sustainable because knowledge is not lost, all right? And it provides that context so that when the next pandemic occurs, or even more frankly, when we try to deal with the current epidemics, of which there are quite a few, right? We forget, for instance, tuberculosis is the world's largest infectious disease killer, and that word wasn't even said once today, I just said it. All right, and so when you put it all together, okay, it is that human capital that is required. And if we are to make investments, which we should obviously, it should be in building that human capital because once it's built, it's not lost. And then you've got people with the right context that is there dealing with today's problems, and then when tomorrow's issue shows up, they're ready there to deal with it.
So what I hear, and trust is, as Robbie, as you suggest, is a much bigger concept. I think of the trust that we have with the FDA and oversight agencies and giving us the yardsticks upon which we can generate evidence for approval. Trust with centers of excellence in pandemic response, with the academic community. Trust with the executive branch, and do we trust our politicians and inform them? Trust with our international partners. Trust with our state public health and our local public health departments. Trust with nonprofits that fund us and incentivize us and point us in the right direction. It's not just trust with the community. Actually, it is trust with the community, and we are the community. And we have to understand that it's multi-directional. And it's multi-directional in a good way, but it's full of distrust, disinformation, and inadequate information as we all sprint in response to a threat. And I think, as you pointed out, Emilio, and as I think you all have pointed out, that a foundational response that transcends all of these domains is our public health system, which has been hollowed out at the federal, at the state, at the community level. And that is the human capital that allows us to identify, to respond, to implement, and to ultimately care for each other. And how do we build that muscle? And how do we sustain that muscle? And I think the comments of influenza, RSV, TB, XDR TB, I too can bring in important concepts of global threats. These are things we've habituated to and gotten used to. And as the earlier panel said, and as we've said here, sustainability. And there are plenty of ongoing examples of communicable infectious diseases with epidemic events that cause 50 to 100,000 deaths in this country alone every year that we've just accepted. And there may be an opportunity for that, as Jeremy Farrar said earlier, to be the opportunity to develop these countermeasures, these infrastructures, these processes, these regulations, these public health approaches that can help us here and internationally, because infectious diseases don't really care about international borders. And so what we learn about how they behave and how we can block transmission and prevent serious illness is something that is exportable across all domains. And I think what this panel has brought forward, in my view, is the complexities of trust and the multi-dimensionality of it, and knowing who to call to get good information when you need it at point of service, point of need, point of communication, and being open with the speed of information and the rapidity with which things may change as we learn, which is a good thing. It's not a bad thing.
Can I add something? There was a great study done by Wellcome Trust and Gallup Institute about trust. And they show that the communities have trust in the scientists of the country when they trust the government, the judiciary system, etc. Everything that protect the communities. So we be very careful when they don't trust, or when your politicians lie, they're killing people.
Agnes?
You want to run for Congress?
Unfortunately, Agnes, you know exactly how to frame it. Thank you. And Karen and I would like to thank this panel for having a wonderful discussion about a complicated concept that we are all trying to handle better as the medium of communication has changed. What I'd like to do at this point is to invite Dean Daly to the stage for closing remarks. And Dean Daly was the, like Jacinda Ard 3.5 years ago, he brought our community together, our community at Harvard, our community at the hospitals, all the teaching hospitals in the state, and the broader biomedical community in the Massachusetts area. And he brought us together to say, how can we respond and how can we be forward-looking? Though he is not an infectious diseases expert, although he may be now, he had the vision of what does it take to respond and how do we dig deep into our resources and our creativity to have the best type of response. And for that, George, we are incredibly appreciative of your helping to create and have the vision for MassCPR and have the vision for a model of how we can respond to pandemics both locally, nationally, and beyond. George?
Lindsay, thank you. And thank you, Karen, for a fabulous panel. I'm George Daly. I'm Dean of Harvard Medical School, and it's really my privilege to close out today's spectacular symposium with just a few of my own thoughts and reflections. I think we would all agree it has been truly energizing to hear from so many brilliant scientists, public health researchers, policymakers, all of whom are involved and have taught us so much about the complex multinational choreography that's involved in pandemic preparedness. I also want to give some formal thanks, first of all, to Boston University and the Maxwell Finland Fund for co-sponsoring this event with Harvard Medical School. I want to call out Nadine Fornellis Martins, who's the Executive Director of Research Initiatives at HMS, and our executive director at MassCPR. She has been involved in organizing and managing all of these complicated logistics. I want to give a special thanks to MassCPR's leadership. Dean for Research Operations and Global Programs, David Golan. Our faculty co-leads, you met Bruce Walker, the director of the Ragon Institute, as the leader of the earlier panel, but he is also joined by Arlene Sharp, the chair of the Department of Immunology at Harvard Medical School, as well as Jeremy Lubin, who's a professor of molecular medicine and a senior virologist at the UMass Chan Medical School. They are the important faculty co-leads of this effort. There are just too many brilliant minds that have been involved in MassCPR over the years to name them all, but I'm especially indebted to our steering committee, which includes leaders from all of the member institutions of MassCPR. And then finally, I want to thank Nancy Sullivan, the director of the National Emerging Infectious Disease Laboratory at Boston University, for chairing the planning committee that put together this fantastic program. Now, just let me briefly bring you back to the opening keynote discussion today that was anchored by the incomparable former Prime Minister of New Zealand, Jacinda Ardern, and two of her governmental advisors who, if I remind you, were awake at 3 a.m. to educate us. New Zealand is a country that differs from the United States in many ways. The nations are separated by thousands of miles. A flight from Boston to Auckland with a short layover takes 21 hours. And the US is about 36 times the size of New Zealand in total land area. In fact, New Zealand's islands placed side by side would fit very comfortably within Colorado. New Zealand is speckled with volcanoes and fjords, while the mainland of the US is home to deserts, forests, and plains. And I don't need to point out the natural and political climates of these countries are far from comparable. But all of that said, our world is so interconnected that countries as far apart as the United States and New Zealand are really part of one bigger whole. We are all passengers on a very small spaceship Earth, and we're all breathing the same atmosphere. So New Zealand's business is our business, and our business is New Zealand's. And we have learned the hard way, in the 21st century, the hard way through the recent pandemic, how a 21-hour flight compresses the size of the world and imperils it. So the Massachusetts Consortium on Pathogen Readiness, MassCPR, was formed at the start of the COVID pandemic to advance the notion of borderless science, the idea that bringing together the brightest minds from our region, but also across the world, would bring together a vast spectrum of academic expertise, and it would allow us to really rapidly propel the research that's needed to combat the world's most pressing challenges, the pandemic and perhaps others. So to that end, the MassCPR Steering Committee is in the process of determining how best to advance pandemic preparedness. With more than $18 million raised to help support MassCPR initiatives over the next 3 to 5 years, we will continue to build, particularly on our biospecimens repository, making good on our practice of sample sharing, data sharing, and information sharing. Now, the $18 million also includes funding that's been received under a new $25 million CDC grant awarded to the Massachusetts Department of Public Health to establish the New England Pathogen Genomics Center of Excellence. The New England Center is the initiative's national lead for education, directly involving the Harvard Medical School Office for External Education, the Broad Institute, and the Massachusetts Consortium on Pathogen Readiness. This work will start with a landscape analysis of the holes in the training of the U.S. public health workforce from a pathogen genomics perspective. So finally, as MassCPR refines its long-term goals, we seek deeper ties with government agencies and policymakers, and we deeply appreciate the many panelists and speakers, many of whom you've seen today are regional, national, and international leaders, and they are now partners in our fight against infectious disease. So your thoughtful coordination is a response to the growing awareness that our interconnectedness in this small world makes local questions globally relevant and global questions locally significant. So we thank all of the speakers. We thank all of you for your engagement in this wonderful symposium. We look forward to making the MassCPR Symposium an annual event and hope that we'll see you next year. For now, we invite you to stay. We have a lunch to be served, and we ask that you take that opportunity to continue the conversation, to forge new collaborations, which is really the essence of MassCPR. Thank you very much, and enjoy the afternoon.